Assalamu alaikum wa rahmatullahi wa barakatuh. Honorable guests, fellow moderators, distinguished speakers, good morning and welcome to our fourth session of this year's conference. Today's session would be shedding light on clinical and molecular toxicology. Wishing you all an enriching and fruitful session. Our moderator, Dr. Nasser Al-Saleh, has pursued his graduate studies in North America, where he first earned a master's degree in pharmaceutical sciences from the University of Alberta at Edmonton, Canada. And then he earned his doctoral degree in toxicology from the University of Colorado, Denver. His work was focused on the molecular basis of disease, treatment, and toxicity. Dr. Saleh joined the Faculty of Pharmacy at King Saud University in 2019, and since then he has been working on multiple projects focused toward understanding the molecular basis of toxicity of different types of engineered nanomaterial, including inorganic metals. Without any further ado, please help me welcome Dr. Nasser Al-Saleh.
Assalamu alaikum. صباحكم الله بالخير جميعا. We are very excited الحقيقة today to hear from our speakers. كويس الآن؟ أعلى؟ طيب. We are very excited الحقيقة today to hear from our speakers يعني on the area of the clinical and molecular toxicology. We have our first talk will be presented by Dr. Khalid Al-Husseini. He is a associate professor at the Department of Pharmacology and Toxicology at King Saud University. Dr. Khalid, يعني, he is the expert in the G protein coupled receptors. Dr. Khalid is a visiting researcher and collaborator at the Institute of Functional Genomics, Department of Molecular Pharmacology in France. He is also a visiting research scientist at the Department of Pharmacology at the School of Medicine at the University of Washington in Seattle. He has very long experience and expertise in the G protein coupled receptors. His talk will be today is about the desensitization and resensitization of the G protein coupled receptors. A lesson from the neuromedin U2 receptors. Dr. Khalid, welcome to the podium.
Hearing me?
Good.
I don't know just how to use this. It's not using here. So I just want to. Hello? Hello? Yeah, I just want to express my gratitude, and I really am feeling honored to be with you here to talk about my previous work and current work. And I really want to get this moment to thank Dr. Al-Mazroui, Dr. Al-Anizi, and all of the organizers who make this comes true. And I'm so sorry, I'm going to take you a little bit from the toxicology part of view. So we are going to talk about the molecular pharmacology of one of the most important family of receptors called the G protein coupled receptors, which I'm going to call it from now on GPCRs. So why GPCRs? Why I get very interested in the studying of the signaling of the G protein coupled receptors, even though it is really complicated, but it is really very promising. How can I just change it? So one of the most important things that if we look at the genome of the organisms, we could find that in Homo sapien, the human genome encoded for 865 receptors of the G protein coupled receptors that we are not including the splice variants that each receptor has like 3 to 5 splice variants. So this is constitute of almost 2 to 3% of the human genome, and that, I mean, it is a very important sign for the importance of these receptors on the cell surface of the cells. In addition to that, the G protein coupled receptors, as you see here, is, I mean, now in the drug market, it constitutes for 45% of the pharmaceutical product that find in the pharmacy. Yes, hello? Yeah, so it's as I mentioned, it constitutes as 45% of the prescription drugs that found in the market, like the alpha beta blocker for the cardiovascular system, and agonists, the serotonin receptor blocker and agonist, histamine, H1, H2 blockers, and agonist also the opioid receptors blocker and agonist. I mean, with the importance or with the fact of the presence of 45% of the drug market from the G protein coupled receptors, 600 of these G protein coupled receptors is still unassigned or not identified for a specific ligand, and they call it orphan receptors. So only 200 receptors have been functionally known and de-orphanized. In addition to that, hundreds of these receptors act as a sensory for taste and smell, and act also as a pheromone receptors. So in addition to all of these, the G protein coupled receptors, at the beginning, it was acting as a binary switch, so agonist or antagonist, so blocking or activating the receptor. However, this theory has been improved, and now we can see that the GPCRs has, in addition to the agonist, antagonist, we have the inverse agonist, biased agonist, which activate a specific pathway other than the other pathways. In addition to that, the allosteric modulators, which is a positive allosteric modulator or negative allosteric modulators, and that really, I mean, widen the diverse action of and complexity of the G protein coupled receptors. Lastly, I just want to also to appreciate the fact that the people who worked with the G protein coupled receptors get the Nobel Prize in 2012, Brian Kobelka and Bob Lefkowitz, for their work, where they begin firstly by purifying the protein of the receptor of beta receptor, then cloning the receptor, knowing the sequence of it, and lastly, they get the crystal structure snapshot of the receptor while it's active. All of these facts make me really fascinated and very interested about how these receptors is working. So before I begin, I just want to give it some basics about the G protein coupled receptors, or the classical signaling of the G protein coupled receptors. As you see, the agonist, when it binds to the receptor, it will attract the G protein, which is on the inner leaflet of the cell surface, which composed of alpha, beta, gamma, and then they will be activated and dissociated to give a specific signal inside the cells. For the alpha, it can be G alpha Q, G alpha I, G alpha S, or G alpha 12, 13, and each one activates a specific second messenger. For example, G alpha Q for the phospholipase C, where we can measure the calcium as an indicator for activation of G alpha Q, G alpha I, like the CB1 receptor working on the adenylate cyclase and inhibit the cyclic KMB. G alpha S increase the cyclic KMB, where G1213 working with the raw G protein, GTPase. Also, I just want to show you this cartoon where the classical G protein coupled receptors, after binding to the ligand, what is happening exactly for the receptor to do its work, then go back to the cell surface. So after binding of the receptor to the agonist, the receptor will begin signaling through the G proteins, and then to prevent continuous activation and toxicity, it got phosphorylated by a molecules called G protein receptor kinases, which is 7 isoforms, and that will lead to the recruitment of the beta-arrestin and desensitized, uncoupled the G protein from the receptor. However, nowadays, they found, in addition to the desensitization by beta-arrestin, it also gives another wave of signal. So after the beta-arrestin recruitment, binding of adaptin P2 will lead to the engulfing the complex of ligand and receptor to the clathrin-coated bit and internalization inside the cells, where they go to the early endosomes, which has a less pH, so it's more acidic pH. And the judgment here, if the receptor get dephosphorylated and the ligand get dissociated, the receptor can go through a recycling and begin another wave of signaling. However, if the ligand cannot be dissociated from the receptor, it will go to both the receptor and the ligand will go to the lysosome, where are they degraded, and de novo synthesis of the receptor has to be done for resensitization of the GPCRs. So all of this trafficking can be measured and can be investigated through to know what is the importance, for example, the internalization, recycling, or de novo synthesis by using of chemical inhibitors. For example, the clathrin-coated bit internalization can be inhibited by dinosaur, or the de novo synthesis can be inhibited by the protein synthesis inhibitor cyclohexamide, and the recycling can be blocked by compound like ilmonensin or bufalomycin, which adjust the pH or increase the pH, prevent acidity, and block the recycling. So I used all of these tools and made sure that they are not interfering with the calcium signal that I'm going to measure as an indicator of the trafficking of the receptor, and measure each step importance of for the resensitization of the receptor. So my job was working with a neuropeptide, have been isolated in 1980 in Japan from the porcine spinal cord, called neuromedian, based on its ability to contract the rat uterus smooth muscles. And in the 90s, 2 receptors have been de-orphanized, neuromedian 1, neuromedian 2. And they found a lot of physiological and pathophysiological action for the peptide and their receptor. The most important thing that attracts the pharmaceutical company for this peptide and the receptors is the ability of one of these receptors to be anorexigenic, which means that it is a very potential target as anti-obesity drug. So this peptide, this peptide work, by binding to 2 important G protein coupled receptor named NMU1 and NMU2, and they have a distinct distribution. For example, NMU1 find mainly in the peripheral system, while the NMU2 predominantly expressed in the central nervous system, and it has the anorexigenic effect. In addition to that, they found both receptors coupled to G-alpha-Q and G-alpha-I, which means increase the calcium signal and inhibits cyclic AMP accumulation in the cells. So one of the most unique characteristic of this neuropeptide when it binds to its receptor, it's what they call pseudo-irreversible or a very high affinity binding to the receptor. So when we measure single cell calcium imaging using confocal imaging systems, as you see here, after basal recovery, when we add the peptide U25, we get a very nice peak followed by a decline. And after 5 minutes wash, when we try to add the peptide again, we couldn't find any further response. So, and we confirmed this phenomena of irreversible binding by cloning this receptor and tag them with EGFP at the C terminus. And as you see here on the green is the receptor tagged with the EGFP, and when we add the peptide which tagged to site 3B, the red color, we try to watch for 12 minutes or to replace them by micromolar concentration of alkyne, replace the peptide. And as you see here in the next picture, there is an internalization and still binding on the receptor. So if we want to compare it to the normal classical G protein coupled receptor, for example, the muscarinic receptor, M3 receptor, we can see after challenging the cell with the carbachol for M3 receptor and wash, when we add again, we see another wave of signal, but it is through desensitization of the G protein coupled receptor. So, at that moment, we want to investigate what is happening exactly. For example, the peptide, when it binds to its receptor, how long does it take to get dissociated or degraded by lysosomal degradation or go through recycling? How much does it take for full resensitization of the receptor? Therefore, we challenge the cells for 5 minutes with the peptide with a maximum concentration, then do 2 wash, and we measure recovery from 5 minutes to 6 hours. Then re-challenge the cells again. And as you see here, it needs approximately 6 hours for the receptor to get full resensitization. So at that time, I was very sure that 6 hours is enough for the receptor and the ligand get degraded by lysosome and de novo synthesis is happening. However, I was wrong. So I tried to do first the de novo synthesis pathway of lysosomal degradation, and I couldn't find any effect of protein synthesis inhibition on the resensitization of these receptors. However, when I investigated the internalization effect and recycling effect on the resensitization, as you see here in the left, here is the control. After 6 hours, we see 100% recovery of the calcium signal. And if we add the dinosaur, which is internalization inhibitor, we got a very nice, significant inhibition of the resensitization. In addition to that, for the recycling, when we add monensin, as you see here, we can get full recovery after 6 hours, but when we add the resensitization. So the first take-home message is this receptor needs 6 hours to be resensitized, and it needs internalization for resensitization. It needs recycling rather than de novo synthesis. On the same days that I was working with this receptor. Okay. Hello? Yeah. So at that time, I mean, Nigel Bennett in Australia was doing a great job with the peptidergic G protein coupled receptors, and he was the first guy who reported that the endothelin converting enzyme, which is the main enzyme that degrade the big endothelin to the active endothelin, which do vasoconstriction. However, they found this enzyme at endosomal acidification or a pH lower than 6, it can degrade another peptides. And their study, they found substance B was a substrate for converting enzyme for the substance B. And if we look at the isoform for the endothelin converting enzyme, there is 4 isoforms, A and C found on the cell surface, where B and D mainly found in the endosomes, which was first evidence. So I tried that, the inhibitor of this enzyme, which was very selective, up to 100 micromolar, and I find, in addition, this is the full recovery after 6 hours, but when we add the ECE1 inhibitor at 30 nanomolar, we find a very beautiful inhibition of the recovery or resensitization. After that, I was interested to see a bigger peptide that bind to this receptor called neuromedian S, which find in the suprachiasmatic nucleus, and it has very important role in the biological clock. And just to see what's going on in the oops. Yeah, so it's isolated from human, as I said, from suprachiasmatic nucleus, and it has an identical N-terminus to as the neuromedian U, and it has also an orexigenic anti-obesity effect, but it was more potent and persistent than neuromedian U. So in functional study, the first fact, both ligand bind with the same high affinity to the receptors, and also looking at the calcium signal, they are equipotent to stimulate the calcium signaling. However, in resensitization process, after 6 hours, we see 100% recovery of neuromedian U, but the neuromedian S was only 60% of calcium signaling has been recovered. So that was the first difference between them on the receptor. And also, we find the same pattern that internalization, recycling is very important. However, the de novo synthesis does not affect the resensitization. But the interesting part was the endothelin converting enzyme that inhibit resensitization of neuromedian U does not affect the recovery of neuromedian S, which means it is not a substrate. And that was the second difference that I found between the two receptors. As you see here, the neuromedian U, and here is the neuromedian S. So in summary, just I want to summarize what I'm saying, is that following the activation of the receptor, it needs 6 hours of time to get full resensitization. And this resensitization depends on recycling, internalization rather than de novo synthesis. Also, NMS3 is equipotent to the neuromedian signaling, but resensitization is much slower, and it does not affect by the ECE1 activity. And that is very important for, the non-classical G protein signaling, which based on the beta-arrestin and the other molecules. I don't know, do I have finished? Okay, so I just want to finish with that. At the end, I just want to acknowledge these guys, Gary Willers, John Chalice, for their, help. Yang Huan for helping me with this cloning. Sophie Bradley was a pioneer in the IBX and calcium signaling. Carl Nelson in isolation of the colonic smooth muscle cell. John Ling helped me a lot in my desensitization experiment. And lastly, Raj Mystery, who was a technician with John Chalice, and he was very nice with me and support me with everything. And at the end, I just want to thank both university, King Saud University and University of Leicester, to give me this opportunity to investigate that and to reach that conclusion which we published recently in the molecular pharmacology. Thank you so much.
Very exciting stuff, but also complicated. Let's try to keep our questions to the discussion session by the end of this session. Our next speaker is going to be Dr. Saeed Al-Qahtani. He is from King Abdulaziz City for Science and Technology. He did his PhD in Purdue University, and he has expertise, and he is also investigating the inflammatory responses of susceptible individuals to inhalation exposure. He will be talking today about susceptibility to inhalational exposure. He has expertise in the nanotoxicology, and without further ado, let's welcome him.
السلام عليكم ورحمة الله وبركاته. ما أنا إلا كبائع تمر في سوق هجر مع القامات العلمية. Where's the slide? The slide. Okay. Thank you, Dr. Nasser, for the introduction. Again, my name is Saeed Al-Qahtani. Today, I'll be happy to share part of my PhD work. Today's talk is entitled Susceptibility to Inhalation Exposure. We have here in the top an image of immune cells that's been influxed into the lung following sulfur nanoparticle exposure in a mouse. And the bright dots are the sulfur nanoparticles. So the engineered nanoparticles are defined by having at least one dimension less than 100 nanometer. So these nanoparticles being synthesized by human for purposes, and these are very small in their sizes. So we have here a schematic figure demonstrate how small these nanoparticles can be. We have a human here. Next to it, we have a microparticle at 60 micrometer in their diameter, which is the same size of human here. If we decided to put in the same amount of human here particle at 60 nanometer, there will be 1 million. And if we decide to go further into the nanoscale, there will be 1 billion. These nanoparticles be released to the environment either incidentally from volcano eruptions, dust here in Saudi, or they can be engineered and synthesized by human for purposes. The engineered nanoparticles usually share the same sizes and characterization that enable them to be used a lot in a lot of application. And we have here an image of the 20 nanometer sulfur nanoparticles that been used in today's project. So we have here a bar graph that demonstrates the global market of products containing nanotechnology. As you can see, they're being increased and projected to continue to increase. And this nanotechnology been incorporated in a lot of applications that touch human daily life, including medicine, construction, and energy sector, specifically in medicine for drug delivery and image technology. Sulfur nanoparticles has anti-bacterial activities, so therefore it's one of the most utilized nanoparticles. And they're being used in medicine for drug delivery, wound dressing, in food industry, containers and plastic bags, in cosmetic as toothpaste and skin creams, and widely in clothes, specifically in socks and army uniforms. Also, they're being used as disinfectants for water treatment and sprayers. So the settings that someone could expose to them can be occupational, biomedical, environmental, and consume products that contain sulfur nanoparticles. So the route of exposure actually depends on the form that you encounter the nanoparticles in. They can be through dermal, through skins, if they are in wound dressing, and maybe if in clothes or sunscreens. Injection in the medicine format, ingestion if you consume products or drink contaminated water, and the main route of exposure is inhalation. So it's obvious that sulfur nanoparticle is one of the most utilized nanoparticle. Therefore, NIOSH has set the recommended exposure level to 0.9 microgram cubic meter for those less than 100 nanometer, and to 10 microgram per cubic meter for total sulfur. However, it's been measured at very, very high concentration in one of the injection room at a facility in South Korea that produce and synthesize sulfur nanoparticles at around 2090 microgram. And the toxicity of sulfur nanoparticles has been linked to dissolution and release of sulfur ion. So both in vitro, it shows toxicity here when they expose human epithelial cells to 10, 25, 50, and 100 microgram per ml. It shows dose-dependent sulfiability. And further inhalation to sulfur nanoparticle induce inflammation. When they expose a mouse here to saturated coated 20 nanometer, they found actually increase in the neutrophils influx into the lung at day 1, which is okay. It's a classical acute inflammatory response. But the neutrophils influx was also present at day 7 and day 21, suggests the inflammatory response could last a while. And the dose that we use in our project is pretty similar to the one being used in this previous study. And we have here an image of this study demonstrate the inflammatory response that occur over time. As you can see here at day 1, there is an influx of the immune cells in the area between the blood vessels and alveolar region, and was also seen at day 7 and to a lesser degree at day 7. Though most of these studies have been evaluated in healthy individuals, where sensitive individual could respond differently, and susceptibility has different meaning to different individuals. What we mean by susceptibility, if we both get outside, exposed to a certain dust or exposure, I'll get sick the other day while you are not. And it's very important because certain individual could have certain underlying mechanism that determine the way you respond to stuff, and also the number of factors that could contribute to the way you respond. And these factors can be being old or young, also the diet that you are on, being pregnant or not, and stress has been also linked to contribute to the susceptibility to response, and most importantly, the disease, where at CDC websites, it tells you that 60% of Americans have at least one chronic disease. And one of the most prevalent disease is metabolic syndrome. Metabolic syndrome, where around 34% of Americans, and even higher in Saudi Arabia, and suffering from metabolic syndrome. And metabolic syndromes are defined by having at least 3 of the following components, including an increase in waistline, hypertension, hyperlipidemia, and hyperglycemia. We have here in the right side of the slide a map of metabolic syndrome prevalence in the United States. As you can see here, it's spread all over the United States, and the yellow flag is pointing to Purdue University, where I obtained my PhD. The prevalence of metabolic syndrome is in between 30 to 35%. So knowing the lipids is dysregulated in metabolic syndrome, and epidemiological studies have shown these individuals are more sensitive to particulate matter, which are 10 and 2.5 micrometer, which are very large in their size compared to the nanoparticles. In this study that's been done by Dr. Shortis at Harvard, they found particulate matter increase white blood cells in mites compared to healthy. And another study shows even the 2.5 micrometer increase the inflammatory markers, including interleukin-6, C-reactive protein, and white blood cells in mites individual. So lipids modulate inflammation by initiate and regulate and resolve inflammation. Here is a graph that demonstrates how we commonly respond to any exposure, usually following the invader, the ADMA. There is a class of lipids known to initiate the inflammation by increasing the recruitment of the neutrophils from the blood vessels, our blood system, to the site of inflammation to deal with the invaders. And later on, this is okay, but later on, this has to be eliminated and resolved. And there is another class by lipids known specialized resolving mediators that's been led by Dr. Serhan at Harvard. He's found out these lipids being released later on and signal to eliminate the neutrophils influx, at the same time increase the recruitment of macrophage that will uptake the debris that left over in the site of inflammation, at the same time uptake the apoptotic neutrophils. If this resolution does not occur appropriately, most of the time and most likely it will lead to chronic inflammation, which could progress to serious disease. And keep in your mind that these specialized resolving mediators function at very, very low concentration. They are very potent. They can function at pico to nano molar concentration. So here's a representative of the first class, the one that initiates inflammation and just say, go, start the action. We have leukotriene B4 that's most likely to bind to the receptor, BOLT1 and 2G coupled protein receptors to increase the phosphoinositide kinase and calcium influx to increase the neutrophil, the NF-kappa B to increase pro-inflammatory gene expression, IL-6, IL-1 beta, and monocyte chemoattractant. The increase of this pro-inflammatory marker expression will increase the neutrophil influx as well as the release of cytokines and chemokines from other immune system. The other class, the one that would say stop to inflammation when it's not needed, is known to be SPMs. Here is a representative of them. Resolve in E1 will bind with this receptor, down regulate the NF-kappa B to down regulate the pro-inflammatory gene expression. This will decrease the neutrophil influx as well increase the phagocytosis. Together, this will stop the inflammation. The anti-inflammatory of the SPMs have been recognized recently. There's a study by Dr. Gowdy and her group at the Ohio State University. They found actually a cocktail of SPM's precursors was able to decrease and inhibit acute inflammatory response in a healthy mouse. When we look here at the neutrophils, the black bar is the increase of neutrophil influx in the mouse following the ozone exposure, as well as other gene expression of pro-inflammatory markers in the lower graph. When they gave the animal a cocktail of SPM's precursors, it decreased the neutrophils influx and the acute inflammation. So, giving you all the background, all the introduction, that the metabolic syndrome is widely prevalent, and we cannot live this daily life without encountering the nanoparticles. And we know that lipids modulate inflammation, and lipids are dysregulating in the metabolic syndrome. So this led us to hypothesize that the dysregulation of lipids in metabolic syndrome could lead to exacerbated response in metabolic syndrome compared to healthy, to sulfur nanoparticles. And targeting these lipids involved in inflammatory resolution could be a therapeutic approach. So we have two aims. The first, we have actually other aims, but today I will just share those two. The first aim is to evaluate the acute inflammatory response in metabolic syndrome to sulfur nanoparticles, and second aim to evaluate the lipids involved in inflammatory resolution and try to interfere those by using statin and sublipid supplementation. So here is the experimental design for the first aim, the acute inflammatory response. We have C57 black 6J male mice, either on healthy diet at 10% kilocalories are coming from fat, or at high-fat Western diet for 14 weeks. This is a well-established model to develop metabolic syndrome. And then animals were given 50 microgram of 20 nanometer sulfur nanoparticle through oropharyngeal aspiration, which is a mechanism to deliver nanoparticles directly into the lung, or to 50 microliter BBS as a control. A day later, an acute inflammatory assessments were performed. So we collect markers of metabolic syndrome, and we evaluate the lung inflammatory response. But we first evaluate the characterization of the sulfur nanoparticles. We purchased the nanoparticle from a company called Nanocomposites, and they are supposed to come in with a size of 20 nanometer. So when we recharacterized them, the hydrodynamic size came out to be around 29 nanometer, and the polydispersion index came out to be 0.20, which tells you actually how uniform your samples are. So this range from 0 to 1. If they are 0, that means each and every single particle in your samples are sharing the same characterization. If it's 1, like each sample in your, each particle in your sample has totally different size. So the accept range is till 0.05, so it's good. So, and the zeta potential came out to be minus 35, and here is the image of nanoparticle that's been used. So, first we evaluate the model to double check that we actually using the right model. We found actually the blue color is referring to the healthy model, and the red is referring to the metabolic syndrome model. So actually, high-fat Western diet increased the body weight compared to healthy, total cholesterol, as well as LDL and triglyceride and serum insulin. So the point from this slide is that high-fat Western diet successfully increased the metabolic syndrome and developed it, which is good. That's the model that we would like to use. Then we wash the lung and perform cell count. And then we spin the samples. We took the supernatant, which is protein-rich. We use it to evaluate cytokines and total protein. And the cell was resuspended and then put in a slide, fixed, stained, and counts. And when we count the neutrophil, we found the neutrophils influx into the healthy animal was elevated, but still okay, as said. It's acute inflammatory markers. Like when you expose something, you're supposed to respond to it. And this response was actually exacerbated in the metabolic syndrome model. And this was also supported and seen by its cytokines when it's measured in the ball fluid, the lung fluid, using ELISA. And ELISA is a very sensitive technique that can measure protein at very small concentration, at picogram per ml concentration. So yes, we did actually saw an exacerbated acute inflammatory in metabolic syndrome. And here's another slide that supports what I just said. So here is the healthy control. You can see the green bar is pointing to the macrophage. And as well as in the metabolic syndrome control, there was actually the red is pointing to the neutrophils. There was elevated in the neutrophils in the exposed healthy animal, but it was exacerbated. There were a lot of neutrophils, as you can see here, in the exposed metabolic syndrome. And the sulfur nanoparticle was also visualizing using hyperspectral enhanced dark microscopy. The bright dots are the sulfur nanoparticles. And you can see here the macrophage was most likely the first cells to uptake the nanoparticles. So at this point, hopefully I was able to deliver that there was exacerbated inflammatory response in metabolic syndrome. And there was, we didn't know whether the lipid was altered or not. And then we performed lipidomics to evaluate the lipid alteration in the lung tissue. And what we found, here are some representative. When we look back to our data, we did not see any change in the lipid that initiate inflammation. We only observe a consistent decrease in lipids that resolve inflammation, and only in the exposed meat animal. So that was fascinating and interesting to us. Here are some two representative. We have resolving one was only decreased in the exposed animal. And these lipids are coming from omega-3 fatty acids. So they are usually been metabolized to resolve and to suppress inflammation. So yes, again, the exacerbated that we observe in metabolic syndrome was associated with the reduction and deficits in SPMs, the lipids that resolve inflammation. And I will just, due to for the sake of the time, I will skip the second aim, or most likely I will cover just the statin treatment. So the statin treatment is basically inhibit the cholesterol formation by inhibiting the HMG coenzyme reductase. And we decided to start off with the statin because it's the most prescribed lipid modulator. And also it's been shown to has anti-inflammatory effects, but the mechanism is unknown. Specifically, there is a recent study that recruited a huge number of subjects, more than 10,000, 90% of them are statin users. So So here is the experimental design. It's pretty similar to the one we observed before, except there is a new component, which is a statin. And we decided to start at 10 milligram per kilogram body weight, because that's the one that most people will start off with worsening their symptoms. They will prescribe like higher dose. And what we found actually, the statin did not change the circulation lipids at the time that we gave the animal, which was 7 weeks. And then statin was able actually to, as you can see here, it decreased the exacerbated. As you can see here, the strip bars, the statin group was able to decrease the exacerbated in exposed mice, but not in healthy. So it's very good because we don't want to actually diminish the inflammatory response in healthy model. And that's great. And the cytokines was decreased in both group. And most interestingly, statin was able actually to recover the deficits and the reduction we observe in lipids that's involved in resolution. So the point from this slide that statin actually decreased the exacerbated response in mixed animal to sulfur nanoparticle exposure, most likely by recovering the lipids amount. And we know that, I'm gonna skip this slide to also show that we also, we confirmed this one by targeted lipidomics, and we found that 14-HDA and 17-DHA precursors treatment was able to recover the resolve in D1. And the ligands, usually SPMs, has to bind with the receptor at, as Dr. Khalid introduced, the ligands and G-coupled protein receptors to cause signal to lead to certain response. So at this point, we know that there was a deficit and decrease in ligands SPMs, but we don't know yet anything about the receptors. So we further measure the receptors, some of these resolvins receptors within the lung tissue used in Western blots. And as you can see here, their level was actually decreased in metabolic syndrome compared to healthy at baseline. And there was a slight decrease with sulfur treatment. So this suggests actually not only the reduction in the SPM's level, but also their receptors could lead to the exacerbated response that we observe in metabolic syndrome. And with that, I would like to conclude that nanoparticle actually exposure could lead to the susceptibility response by altering the SPMs and lipids metabolism. This not only their amount, but also their receptors. This will lead to recruitment of neutrophils to the site of inflammation and most likely continue the risk of pulmonary disease. So lipid supplements and statin was able to actually recover the level of SPMs and decrease the exacerbated response. So here are some future direction. We did not actually evaluate the lipid mediator inflammation at very early points where they are being actually reported to signal early on following the exposure. And we did not actually do the cell-specific response. We only showed that the macrophage was the most cells to uptake the nanoparticles. And we could also extend this study by doing repeated exposure. Systemic effects, specifically sulfur nanoparticle, have been shown to actually transport far away from the lung to other organs, specifically liver and spleen. And also using MALDI image, this technique actually could help us to quantify the lipids within the lungs, because some people could actually miss the part that the lipids could be actually elevated. And with that, I'd like actually to acknowledge the Dr. Shanahan's lab, our collaborators at Bindley, at Purdue University for their help with metabolic syndrome. And I'd like actually to express my gratitude to CACS for supporting me offer my graduate school and the funding agents. And I'd like also to thank everybody for inviting me to share my work.
Thank you, Dr. Saeed. Allah يعطيك العافية. Very interesting research. I think we should stay away from the silver nanoparticles in this case. We'll talk, inshallah, about it more in the discussion session. We will shift gears now, and we will have a talk in clinical toxicology. It will be presented by Dr. Ahmed Al-Shatouri, and he is an MD clinical toxicologist. He is from Kuwait, from the Toxicology Center in the Ministry of Health in Kuwait. And the title will be The Role of High-Dose Insulin Euglycemic Therapy in Toxin-Induced Cardiogenic Shock. Please join us. Thank you.
Assalamu alaikum. How are you, everybody? It's a great honor to be with you today. Today I'm going to talk about role of high-dose insulin euglycemic therapy in toxin-induced cardiogenic shock. Okay, let's divide it into parts. The first part is the high-dose insulin. To what extent the dose will be high? You know, famous example for using regular insulin, act rapid, is DKA, okay? And the dose is 0.1 unit per kg. Our dear pharmacist, if you get a medication order stating that we have to give the patient 1 unit per kg, it's 10 times more than, or to give the patient 10 units per kg, it's 100 times. 20 units per kg, it's 200 times. I do believe that you will consider it a medication error, okay? But it's not a medication error. We are giving act rapid, regular insulin in high doses in order to treat cardiogenic shock induced by toxins. What type of toxins? Famous toxins, beta blockers, calcium channel blockers, and maybe other xenobiotics that can cause cardiogenic shock. Our agenda, I'll give some introduction. Mechanism of action of high-dose insulin, pharmacokinetics, pharmacodynamics, dosage, administration, and safety issues. Beta blockers, actually, the beta receptors in our heart, we have beta 1, it's like 80%, beta 2, nearly 20%, and very little beta 3. Our concern here is for beta 1. Stimulation of beta 1 will lead to positive chronotropy, increase in the heart rate, positive dromotropy, increase in the conduction through the EV node, and positive inotropy, increase in the stroke volume and the cardiac output. So, inhibition by beta blockers of the beta 1 receptors will cause bradycardia, negative chronotropy, and it may cause different type of heart block, first degree, second degree, MOPTIS 1, MOPTIS 2, or third degree heart block, and will cause negative inotropy, and this eventually will lead to the cardiogenic shock. It's very important to understand the problem to figure out a solution and to understand this pathophysiology or at this mechanism of action in order to try to find the proper treatment for cardiogenic shock induced by toxins. Beta receptors present as well in the blood vessels, and the type of receptors is beta 2. We have alpha 1 and beta 2. Stimulation of alpha 1, this will lead to vasoconstriction. This will increase the systemic vascular resistance and increase the blood pressure. And stimulation of beta 2 will cause vasodilation. Beta blockers will block the beta 2. So we are expecting unopposed alpha 1. Unopposed alpha 1 will cause vasoconstriction. To be honest, it is minimal in beta blocker toxicity, but such vasoconstriction will impair the tissue perfusion. Okay, so my heart is failing to pump the blood due to bradycardia, negative inotropy, cardiogenic shock, and I'm putting such resistance inside the weak heart. So the problem here will be impairment of the tissue perfusion. This is caused by beta blocker overdose. I'd like a solution for this. This is a stepwise approach in beta blocker toxicity. When we deal with any case of a beta blocker overdose, there is a stepwise approach. First, we are going to use IV fluid, atropine. This is for the mild cases of beta blockers toxicity. And usually, in severe cases, it is insufficient. The next step is giving glucagon. Okay? The mechanism of action of glucagon, it will stimulate adenylate cyclase. This will increase cyclic EMP with increase in the sarcoplasmic load of calcium, and this will cause positive inotropy and increase coronary blood flow and cause some vasodilatation. So it seems good treatment option for beta blocker. Remember the last slide, my problem is failing the heart to pump the blood and some sort of vasoconstriction impairing tissue perfusion. So glucagon is good for this. But we have some limitation with using glucagon. The effect is transient, just like 15 minutes. And it's famous by its tachyphylaxis. Tachyphylaxis, I have to increase the dose in order to get the same response. So in this case, I have to give high doses of glucagon or to add additional therapy to glucagon. It may cause hyperglycemia, it may cause hypocalcemia. Another treatment for beta blocker is calcium. Actually, it's more common with the calcium channel blockers. Calcium will cause mainly vasoconstriction peripheral and increase the blood pressure. And you know, some references does not recommend giving infusion, so I have to give a lot of boluses. And I have to monitor the patient for the calcium level total not to exceed 14 or not analyzed not to be double the normal. So, and effect is transient as well. This is the high dose insulin that I'm going to talk about today. Another treatment modality is to give catecholamines, vasopressors, inotropes. So imagine I give my patient noradrenaline. What will happen? Noradrenaline, for example, will cause severe vasoconstriction because it acts mainly on alpha 1 receptors, and this will impair the tissue perfusion. I have a problem with tissue perfusion with beta blocker overdose. And at the same time, it will put much more systemic vascular resistance, and this will impede the failing heart to pump the blood properly. So it is not recommended. And in general, catecholamines needs central line, hemodynamic monitoring, large doses, and it will impair tissue perfusion, and it has a pro-arrhythmogenic effect. So it's not good a choice. Another treatment modality is the ECMO. ECMO, yeah, we have two modes of ECMO, veno-venous and veno-arterial. Here we are going to use veno-arterial because it will support the circulation. But ECMO will be the last result after filling of the other treatment modalities. Some references advise for intravenous lipid emulsion, but actually has limitation. And if we use intravenous lipid emulsion, we cannot use ECMO as well. Okay? So this is the problem, and this is the treatment modalities that we have. The best is high-dose insulin. This is a study, annual study, done by Kearns et al. It's a canine model of propranolol toxicity. The first group received insulin and glucose. 6 out of 6 survived. The second group received glucagon only. 4 out of 6 survived. And the third group, epinephrine. 1 out of 6 survived, and the placebo survived. The conclusion, insulin is a superior antidote compared with glucagon or epinephrine in a canine model of acute beta blocker toxicity. The second xenobiotic is calcium channel blockers. Actually, calcium channel blocker will interfere with carbohydrate processing by inhibiting pancreatic insulin release. Actually, we have here L-type calcium channel blockers in the beta cells of the pancreas. What happens if calcium will stimulate the release of insulin? Blocking such calcium channel by calcium channel blocker will impede the release of insulin. And this will create a state of hyperglycemia. And clinically, hyperglycemia in calcium channel blockers is a bad prognostic factor. Okay? Moreover, calcium channel blockers will create a state of insulin resistance. Here, this when insulin binds to its receptor on the myocytes, for example, they will stimulate PKP, and this is transporter, glucose transporter. No, it's not working. Glucose transporter will help glucose to enter inside the myocytes. Calcium channel blocker will block this step, and glucose will stay outside the myocyte and other cells, and this will create a state of insulin resistance. Why insulin is very important, or glucose is very important in this case, we'll know in the next slide. This is another study, this case series. High-dose insulin, a consecutive case series in toxin-induced cardiogenic shock. I'd like to summarize it for you. We found that the main maximum insulin infusion rate, I'm infusing insulin by like 8.35 unit per kg per hour. In other references, we reached up to 22 unit per kg per hour infusion of ACT rapid. The mean duration of insulin infusion was 23.5. In other references, they reached up to 49 hours of infusion. And we will know in the next slides that when we stop insulin, we have to continue glucose infusion, and this was done up to 25.2 hours. 7 patients had pre-existing vasopressor therapy. All were tapered off vasopressor while on high-dose insulin. So the 7th patient was on vasopressor, and when we start the high-dose insulin, we tapered off the vasopressor. 1 patient died due to pulseless electrical activity or asystole, cardiac arrest, within 1 hour after cessation of 9-hour insulin infusion. So the stoppage of insulin jeopardized the patient and caused cardiac arrest and death. And this was due to re-administration of norepinephrine. I'm giving norepinephrine, vasoconstriction, systemic vascular resistance increased, and the cardiac output decreased more and more. Okay? Actually, it's not a new treatment modality. It's from 2 decades, but it may be not famous. And it has gained increased attention and importance in management of a spectrum of critical illnesses, including sepsis, heart failure, and now cardiovascular drug toxicity. In xenobiotic-induced myocardial depression, the use of high-dose insulin with sufficient dextrose can restore normal hemodynamic status, increase the cardiac output, and improve the tissue perfusion. You know, the heart, the myocytes, during rest, the energy source is free fatty acids. On the other hand, during the stress, it shifts the energy source from free fatty acids into glucose. So you imagine that I'm putting such stress on the heart by beta blockers or calcium channel blockers, it will need the glucose instead of free fatty acids. So when I give the insulin with high dose with glucose, so I'm providing glucose as the energy source during the stress of my sites to increase the force of contraction and to increase the cardiac output. What is the mechanism of action? As I informed now, high-dose insulin will support the metabolic demand associated with cardiogenic shock. It will provide glucose for the stressed myocytes. This will improve the myocardial contractility. Moreover, insulin will increase the available calcium, and this will increase the sarcoplasmic reticulum calcium load. When I increase the calcium, this will increase the force of contraction as well. This is one limitation. This contraction typically takes some time, from 15 up to 60 minutes. So we advise to initiate the high-dose insulin as early as possible in the severe cases of beta blocker toxicity. Some references can advise by giving epinephrine as a bridging during this time and to rapidly wean the epinephrine. Some advise for giving glucagon until we prepare for the high-dose insulin. High-dose insulin will cause vasodilatation peripherally. So I am improving the tissue perfusion by such vasodilatation. And insulin will not significantly affect the heart rate. It's good not to affect significantly the heart rate because increasing the heart rate will increase the oxygen consumption of the tired heart. So it's not acting like to increase the heart rate like epinephrine, for example, or other vasopressors that will act on the beta-1 receptors of the heart. Moreover, insulin will increase the lactate uptake. In calcium channel blockers, we have two bad prognostic signs: increased lactate, lactic metabolic acidosis, and hyperglycemia. High-dose insulin will increase lactate uptake and will use it in the Krebs cycle in a way to provide energy source for the myocytes. So I am getting benefit from this lactate by high-dose insulin in order to improve energy sources for the heart to improve the force of contraction. Pharmacokinetics and pharmacodynamics. Regular insulin, it's act rapid, administered intravenously. The peak plasma concentration is immediate. Onset, it takes from 15 to 40 minutes. Volume of distribution, 21 liter. Protein binding is 5%. More than half insulin metabolized for liver, and also a sizable degree that occur in adipose tissue, muscle, and kidney. And the elimination half-life of intravenous administration is roughly 5 to 10 minutes, and it's partially eliminated in kidney and the bile. It's very important. What is the dosage regimen? How we administer such high dose of insulin? And is there any safety issue? You know, I'll start by giving bolus of 1 unit per kg act rapid, regular insulin. It's 10 times the usual dose of DKA, okay? But please, stop. Before giving such bolus, I have to check two things. This is for the safety of the patient. Number one, the blood glucose level. If it is less than 300, in other references 200, we should, before giving this bolus of high-dose insulin, to give the patient 0.5 gram per kg of glucose. Okay? Another issue. Potassium. You know, insulin will cause hypoglycemia and hypokalemia due to shift of potassium intracellularly. So we have to check the K. If it is less than 2.5, we should compensate and give like from 20 to 40 milli equivalent over 2 hours, and to check the level before giving such high dose of insulin as a bolus. Actually, we give a bolus just to saturate the receptors for the sake of giving infusion. I'm not just giving the patient the bolus, 1 unit per kg. I'm going to infuse the patient 1 unit per kg per hour regular insulin. So it's like 100 times the normal, sorry, it's 10 times normal dose like DKA. During the infusion, I have to give dextrose infusion as well, same dose, 0.5 gram per kg per hour, in order to maintain blood glucose between 100 and 250. And to monitor blood glucose every 15 to 30 minutes until patient is stable, then we monitor 1 to 2 hours. And we have to measure potassium hourly and to compensate if it dropped below 2.8. Okay, I'm now infusing the insulin at this dose. How I'm going to monitor the patient? I'm echo every 15 minutes, 30 minutes, and to monitor the response. If no response, what I'm going to do, I'm going to increase the infusion rate up to 10 units per kg per hour. It's 100 times over the DKA dose. And to still monitor the patient, I can increase up to, in some reference, 22 units per kg per hour. For how long I'm going to give this regimen? 1 to 2 days. And after stabilization, if I achieve my goals, I have to reduce the dose by 1 unit per kg per hour. In other references, we can reduce it 5 units per hour. It depends on the dose I'm using. If the patient is stable on 1 unit per kg per hour, it is not logic to reduce 1 unit per kg per hour. We can reduce 5 units per hour. If we reach like 10 units per kg per hour, we can reduce it like 1 unit per kg per hour. It's very important to continue dextrose infusion after stoppage of insulin and to monitor K level. This is the dosage regimen and administration and safety issues. What is the ultimate goal of treatment? Ultimate goal of treatment to increase cardiac output and to improve organ perfusion, like mental status, adequate urine output, and to reverse metabolic abnormalities like serum lactate, bicarbonate, and pH. Okay, improvement in mean arterial blood pressure is okay. Heart rate is okay, but it is not the big issue for me. The big issue for me is to increase the cardiac output and to improve the tissue perfusion. Take-home message: high-dose insulin, bolus followed by continuous infusion, early in resuscitation of severe beta blocker, calcium channel blocker-induced myocardial depression, augment cardiac function and perfusion. High-dose insulin support the metabolic demand associated with cardiogenic shock and augment calcium processing. It may open for us a good area for research, not only to give this high-dose insulin for beta blocker and calcium channel blocker. We can look for other xenobiotics that can suppress the heart and try this for these xenobiotics. Specific monitoring for glucose, potassium is very important. In addition to surrogate marker of tissue perfusion like cardiac output, urine output, bicarbonate, pH, and lactate. Insulin is a superior antidote compared with glucagon, vasopressor, and inotropes like epinephrine in acute beta blocker and calcium channel blocker toxicity. Thank you.
Thank you, Dr. Ahmed, for this informative talk. So our last but not least talk will be given by Dr. Hisham Abdul Kamil, and he is currently working as a head of proteomics unit, PI, and associate professor at the Obesity Research Center at the College of Medicine in Kingside University. And his talk will be about the proteomics as a tool in advancing molecular toxicology research. Please, the floor is yours.
Assalamu alaikum. So first, I will thank the committee organization to invite me to share with you his knowledge, especially in the proteomics. So my talk will be in toxicoproteomics. There is two words here, toxicology. We integrated between toxicology and proteomics. So in our proteomics lab in Kingside University and College of Medicine, so it's not limited to study just the clinical proteomics because we are there in College of Medicine, so our availability for the sample from the biobank or collaboration with also with physicians that they provide us a sample. So more our focus is in biomarker in disease, endocrine disease or cancer, etc. So it's not limited, as I said, in clinical proteomics. So also we work in toxicology proteomics in collaboration with our colleague in College of Pharmacy. So toxicoproteomics. So toxicoproteomics, this approach we can use to identify the K or the protein K, and also to identify the pathology and the pathway and network that in our biological system that changed or affected by a response for any chemicals, entity, or drug. So now. Recently, really, the company, they developed a good instrument, so a sensitive instrument and sophisticated instrument, mass spectrometer, that can identify a wide range of protein, and we can do qualitative and quantitative of any exchange protein between any group of between the group and also the quantitative protein that affected by a substance, toxic substance, our body exposure, for example. So also the study of toxic proteomics that can explore that molecular mechanism of action of variety of drug or any toxic substance enter in our body. So in benefit of toxicoproteomics, so we can discover a biomarker, a drug target, and all this data we can integrate it for to come up with now personalized medicine, so we can predict the toxicology in the patient. So proteomics, the first time proteomics was first quantified in 1994 by Australian postdoc fellow named Mark Wilkins. So just I give briefly identification of proteomics. Yesterday, Dr. Asiri gave a large identification or describe for proteomics and metabolomics. So proteomics is large-scale study of protein. So we know this protein is secreted by the cells from any organism. So we get more information. We can get it from the protein. So also we can identify the protein and also the modification of protein, especially in post-translation or post-translation. So this is really give us more information about the response of the cells. So why proteomics? There is an advantage of to use in proteomics than the genomics and transcriptomics, especially. So, so it gives us a better understanding of an organism than genomics. There is a limitation of genomics that made proteomics a better approach. For example, DNA sequencing don't show how protein the function or how biological processes occur at the level of transcription of gene, give only a rough estimation of its level of expression into a protein. So also there is other advantage of proteomics. We can identify the modification in protein itself, for example, cross-translation or modification. So also we can find a protein expression between two groups, for example, potential biomarker. We can use it in, we can also develop a diagnostic tools and therapeutic agent. So now, as I say, recently the company, they really develop now a lot of software and database and instrument. They now have really a good, also the bioinformatic and data, bioinformatic software, so can facilitate for us for analysis data. So for example, also for mass spectrum instrument, now we have really a good, very high sensitive and stabilized equipment for in mass spectrometry. For example, the orbit trap and Kitov. So also we have now we have database, we can protein mass, peptide, and sequencing of peptide we can also identify. So this current proteome technology using there is, for example, you can use for the first we need to separation of protein, the map of protein. So we can use 2D gel or liquid chromatography. Liquid chromatography is first or second dimension. And the protein identification we can use, for example, MALDI, as we have in our lab using peptide mass fingerprint or LCM, SMS, high resolution we can use, for example, Orbitrap or Kitov. So we can use also for quantitative proteomics, we can labeling free as we use it in our lab, or isotope coded way as ICAT or iTrack. So there is two approach for quantitative proteomics using and to compare between two groups, for example, control and disease. So we can use on-target proteomics and target proteomics. And also for mass spectrometry, we use two different instruments. So for on-target proteomics, we can use in the first, we have a separation of 2D gel or by nano LCM, by nano chromatography. So then we have high resolution, we use, for example, Orbitrap or Kitov for on-target proteomics. We will identify profiling and do statistical analysis to compare between the profile between the groups. But target proteomics, we use a triple quadruple instrument. So we use parallel reactant monitoring or selective reactant monitoring targeted approach. So we have, for example, a panel of proteins of one from 1 to 10, and then we win down. So and we have developed a method to quantify, to do absolute relative or absolute quantitative. It depends what we need to do. This is a proteomics application. We have large field. We can apply the proteomics. So can biology discover, drug discovery and development, system biology, agriculture, food science, and biohazard microbiology, medicine, pharmacy, and toxicology. So we have large field. We can apply our proteomics application. See the sample we can use in for our analysis. So most we use in a serum protein or plasma. So there is 19% non-informative abundant like albumin and others. So what we do the preparation sample before we do a depletion for this protein. We have a commercial kit and we do the depletion for the most abundant protein without non-informative. So we can use also the organ like liver, kidney, brain, etc. So and then we can use body fluid from this organ. So we have a large source of sample we can use for proteomics, and each sample have a protocol, standard protocol to extract protein from it. So this is just a workflow how can use it for toxicoproteomics. So we can use animal or human from tissue or blood. So we can do and target proteomics, use 2D DIGE as we use in our lab. And we can use a mass spectrometry, LCM, SMS, or a target protein as protein array or cells. So we can find some mechanistic toxicology, disease diagnostic, biomarker, and predictive toxicology. We use in personalized medicine, so or risk assessment. So and why this with high specific clinical toxicology biomarker. So we will find that we can use it in, for example, in identified protein fingerprint for toxicology response, or clinical intervention, or for classification of complex multi factors, so etc. So there is many lab in the world working in toxicoproteomics. So in as application, for example, they focus it for to study some chemicals, toxic chemicals, for example, epoxide, or there is nicotine. So there is a lot of chemicals, toxic chemicals that they use. The platform they're using for this 2D mass spectrometry or LCMS or 2D DIGE, and the tissue they use or blood from human and rats. So what the result they found, for example, protein change or some mechanistic, and etc. So also here in the liver, because the liver is the most organ affected by toxic chemicals or drug. So there's lots of work also in the rat or human, the compound that they use it, they study in for toxicology. So total liver or cells or cell line. So there is the technique using DIGE as we have in our lab, or iTrack and the MALDI-TOF. And or to the dimension MALDI-TOF, and what observation they see, for example, some mechanistic pathway, and etc. So now I will just show you some study we do it in our lab for toxicoproteomics. So one most interesting study we do it in collaboration with our a colleague in the College of Pharmacy in King Saud University. So the serum proteomic profiling of patients with amphetamine use disorder. So it is publishing drug and alcohol dependent. So well known, this all of you know, this amphetamine is a powerful stimulation, but unfortunately they're using for they're using for addictive for the young and in many countries. So there is really an effect for these toxic molecules. So this molecule is used for treated many disease. So using for some medical conditions, strict conditions, but unfortunately they're using for abuse and high addictive. So the mechanism underlying this process of amphetamine is still not fully understood. There is some study they use in this study proteomics, study this molecule, but related to other disease like schizophrenia, Alzheimer, and etc. So we applied the untarget proteomics technology. So we use a 2D gel, DIGE, and copied with mass spectrometry TOF. So I will just go here. So there is a two group. We compare two group, amphetamine group, the 10 and control group. So I will mention here that all the patient they collected from enrolled at Al-Amal Medication Complex for Mental Health in Riyadh with ethical committee and etc. So this is the demographic and clinical and demographic information from the patient. We have two, a group, a control, and amphetamine group. So they have the age, a matched age, gender, all of them male, and also material study, and also the duration of the abuse for this drug. So this is the workflow. So we have two groups, and we have a plasma serum from the patient, and with extraction protein, and we do a separation, so a second dimension, and then we do statistical analysis between two groups to elevate the protein or differential protein between statistical significant protein differential between two groups, and do a gel preparative to exit the band, and then to identify ID protein by MALDI-TOF we have in our lab. Then we do that to identify by database sequencing. So we do bioinformatic network pathway, and some we do also the validation by Western blot for some proteins. So this is just to show you an example of this gel. So the map of all proteins. So for example, we labeling control by SIDI 3 with the green color, and labeling the amphetamine group by SIDI 5 in red color. So, and the yellow color is the merged or matched between control and amphetamine group. So SIDI 2 is the pool used as internal standard. There is the map of protein. There are significant difference between two groups. Red color is upregulation in amphetamine group, and the green color is downregulation in amphetamine group. So this is the just example, just one page. We have more than, I think, 100 protein. They are different expression between two groups. So we have, for example, spot number, axis number in in unit prod, so protein name, mascot, and the p-value of a statistic should be more than 0.005, and also the ratio between the fold change, which we always 1.5 up. So we have two, for example, 2, 3, or whatever. So, and also the expression up or down. So here just also this figure shows the difference between two groups, the expression for each protein, and the PCA or principal compound analysis show us really this clear differential between two groups. At 10 to 65%, so the variability is very clear, the separation between the group. So we identify this for this study. We identify 78 protein, 71 protein they are upregulation, and 7 they are downregulation in sample of amphetamine exposed compared to the control. So we have, for example, some significant upregulation protein like zinc alpha-2 glycoprotein and haptoglobin, etc. And downregulation, for example, we identify apoprotein E1 and the prothrombin. So after we identify all these protein, we go to a bioinformatic using EPA network pathway. And we enter all our protein in this software to get up with a network pathway to show us the interaction. The red color is the protein up in amphetamine group, and also the green is the proteins down. So this shows us the interaction between our group with other proteins, and also the NERDs like NF-kappa B and MAP kinase. So this is really more informative. So we get this map to show us the interaction between with what the network affected by amphetamines. So this is also just the distribution of our protein identification, level of function and location. For example, more the change in function is catalytic activity or location extracellular region. So this is for just we confirm some protein by Western blot to just for confirmation our protein. So our work it was really a first time we do this has the comparison between in human plasma between a control and amphetamine patient amphetamine use disorder. So we demonstrate that this has affected exposure of amphetamine on various serum protein inside the men. So we have 78, we identify 78 protein changes, and also we do a network pathway. So all this protein may be involved in inflammation, inflammatory and immunological and neurological disease. So the second study was also we use a serum protein analysis of cannabis use disorder in male patient. So we have this is well known the smoking of cannabis is large used in the world. So and when now this is really a toxic and contains some molecules that affect in neurological system. So so in this study, we also applied on-target proteomic using 2-DIG and mass spectrometry. All this study we conducted in our lab, proteomics lab in College of Medicine. So I just switch here. So we have two groups. So all of them control and cannabis use disorder, matching age. All of them they are male, and also we extract. We have all the demographic. So there are no infection disease, cannabis dosage from, so all of them smoking and also the cannabis use history. So the same, we have these two groups, we collection of serum, we do extraction of protein, 2D DIG and Malditov and bioinformatics. So the same what previously did for amphetamine. So this is the protein, they are significantly changed between two groups. So this is just one page for what the protein identification, the protein differentiation statistically between two groups. We have P-ANOVA and also the ratio between two groups and also the expression down or up. So also here the principal component show us really a good separation and even a variability between two groups. So here we identify 121 protein. We successfully identify the differentiation between two groups. The 55 proteins, the upregulation, and 66 downregulation in sample comparison of cannabis use disorder patient. So here we go here. So also we did a bioinformatic analysis. We do a network pathway. So we identified the network pathway with score with 52 related to the free radical scavenger, the cellular compromise, and inflammatory response. So here also we do a partner analysis to see the classification of identical protein in molecular function level, biological process, and cellular compound. So in this study, we have really 121 protein effect changed between these two groups, but most we just selected some interesting protein. We have a level of, for example, albumin is downregulation in patient with cannabis use disorder. So the time is limited. So, I will skip this So in our also in our lab, our research study, we study a lot of the chemical effect and biological system. So, for example, our lab we using a study for thyroxine between urothyroid and thyroid and hypothyroid. So we use the plasma, and also we use it in urine. So also we use metabolomics to study for hyperthyroidism using thyroxine drug, and also we use new medicine now is a liraglutide saxenda for treated diabetic and obesity. So we do also plasma for it. So also the metformin in obese patient, metformin also in single dose for healthy, for study the pharmacology of this medicine. So dexamethasone we now also for animal, we for the organ, we take it from liver, heart, and etc. So we do also the proteomics for this. This is last, I will just application mass spectrum. So this is really now a new technology you can use in paper spray. So without any separation chromatography or gel, just to put loads samples spotted in the paper and do analysis for it. This is we can use it especially in a quick screening, for example, for the drug, for example, to analyze for cocaine or for paracetamol when they use it they take it overdose. So we can use this in emergency. When the patient comes, the emergency, we don't have time to save his life, so we can do this quickly, dry spot blood, and you do analysis without any separation, with an ambient temperature. 1 minute, you get this patient, you have. Also, we can do quantitative with this. We have high, you can screen it with high quantity of paracetamol, cocaine, or any drug. So also we can use it to detect some organ or chemical organic. So for example, a pesticide in the leaf for the food, also for agrochemicals, we can use the fruit directly for mass spectrometry to identify some agrochemicals. So also for forensic analysis of purple and pink, so fraud, if you sign the check, someone you can do it in mass spectrum, you can do the different diseases really now. In United States, they're using also in the airport to analyze if the NT or many application now is quickly to do it. So this is just our proteomics lab in King's Health University. So this is many, we have also many national and international collaboration, and we are also opening for any collaboration. So and thank you.
No, it's okay. شكرا. شكرا لكم جميعا. Thank you for being and sticking here. The good news that we have 15 minutes, right, for the discussion. 10? Okay. So it's time for the questions. We have our speakers on the podium. So please, if anybody has a question, we have another microphone also there.
My question is for Dr. Ahmed. Thanks for a very informative talk. I'm sure you know that there are several studies that came out right now that were questioning the effects of atropine, for example, in the treatment of calcium channel blockers and beta blockers, and also even glucagon. And they mentioned that these drugs are just reversing the bradycardia that we might see, but they're not improving the outcome. And that the use of these drugs was basically depended on case studies. Are you aware of any studies, the randomized control trials that have tried insulin for treating a calcium channel blocker and beta blocker toxicity? That's the first question. Second question is, when do we decide to use ECMO? So when do we decide to use ECMO if the insulin therapy fails? Thank you.
Okay. Concerning the second question, Doctor, using ECMO is our last result, okay? So at the regimen given, I start with bolus and then infusion, and up to 22 units per kg per hour of actrabin can be infused. Actually, this is a case report. They reached to this level of dosage, and the patient improved. As I informed, the patient improvement is assessed by the cardiac output, like doing echo, and the tissue perfusion in the form of improvement in the mental status, urine output, and something like that. So the maximum dose reached and achieved control is 22, okay? Actually, it will depend on your clinical assessment, starting ECMO or not, okay? Concerning the second question, I heard it hardly, but you are talking about... No randomized. All our data is collected from animal models and from case reports and case series. In the future, we wish to do something like that. Okay.
All right, thank you. Any other questions from the audience? Okay. I think I have a question for Dr. Khalid about whether other diseases could affect the signaling pathway that he was interested in, that he did the research on, the receptor basically. Like, let's say diabetes, for example, or any other metabolic diseases.
Hello? Yeah. So thank you so much for this question. Just, I think it is very interesting that what I've seen during my research with this receptor have been translated to a disease case that I never expected. So for example, this receptor, as I mentioned earlier, it needs 6 hours for full resensitization. But we decided in the lab, because of the economy of the lab, to change the media and used the media that we are using is the DMEM, which contain high glucose, like 4.5 gram per liter, which means 15 millimolar. The surprise that I met is the whole profile of resensitization is changed. Sorry. Happened during that. The resensitization, instead of 6 hours, it stays. I got full resensitization with 2 hours, which means the ligand dissociate from the receptor within 2 hours. And that means all of my work was rubbish at the beginning. I get surprised about it. However, I began reading about what's happening in high glucose. And it turned out in very good journal, there was 2 reports said that high glucose level in uncontrolled diabetic patient have a very high expression of ECE1. And I tried to test this hypothesis by the addition of the inhibitor of this highly expression, because the expressions increased 20 times. So the take-home message, so for example, in female with uncontrolled hyperglycemia or uncontrolled diabetes. The neuromedian U is expressed in the uterus, and it might help in the labor process. So that means we are still investigating that. So it might affect the ability of the contractile effect plus the oxytocin and the other things. Yeah, thank you.
Thank you, Dr. Khalid. Any questions from the audience? Do we have another one? It's working now. Dr. Saeed, the silver nanoparticles, tell us about it. So from the research you did, what do you think susceptible people should do when they exposed to, let's say, products that have silver nanoparticles? Should they be worried about it? What about the people who are using the statins, for example, or those medications? Are they in a better situation or not? Please.
Well, this is very interesting questions, and I will answer this question based on the data that we collected, and it's been performed in animals at this point. But this mechanism is also fundamental, I would say, to all nanoparticles, because susceptible individual been shown to respond to statin as well as other certain precursors. So I was not actually included a specific potent resolvent that we just published at the particle and fiber toxicology recently, where we investigate a certain resolvent, because we cannot actually, some people would recommend people to, or susceptible people, to just consume a lot of omega-3 resource like fish and other oils. And this could be okay, but sometimes you need to be like more specific to go further to investigate a certain resolvent by itself. And resolvent D1 actually showed its ability to actually function as a statin, which is very interesting, and this can be actually been translated to clinic setting. So the point is that based on our data, statin actually did reduce the exacerbated response in sensitive individual to nanoparticle exposure. And this could be the case in human as well. But we can actually recommend people to just consume statin and go and outside and expose to nanoparticles. So also, this is also another suggestion to sensitive individual to limit their exposure at certain settings. Like if you are working at a certain mining or certain facility that produce nanoparticles, you better watch out your shifts and make sure you are not at the hot spots that produce nanoparticles. So be reasonable as well. Do not say, okay, I'll expose to the nanoparticle and then I will use treatment later. It's better sometime to actually prevent, like take certain medication before, for example, go to the work settings, and this could actually prepare your immune system to handle the exposure. So it's a very complicated situation, and it depends actually on the individual. So we can not make a general advice to everybody. So it's by individuals, I would say.
Dr. Said. Any other questions by the audience? We'll give you another chance. Take some time, we'll give you some time. Any questions? No? So time is up. Okay, so my moderator assistant, actually, she is saying that the time is up. Let's give her a warm clap because she has been helping in this session, to be honest. Thank you very much. Thank you all for sticking here to the end of the session. Thanks to our speakers for the great talks they gave today. Thanks to the organizers also, and on top of that, Dr. Mahal Mazrou, Allah yatih al-afiyah, for making this conference happen. It's very great to have everybody here, and please, I think we'll have a 30-minute break, and then we'll come back for the next session.
Before the break, we have the awards.
No? Okay. She's the boss here. We go after.
By that, we conclude our first session for today. Thank you for your attention. As for now, please help me welcome Dr. Mahal Mazrou and Dr. Ahmed Al-Anizi to kindly thank our speakers. Starting with Dr. Nasser Saleh, our moderator. Dr. Khalid Al-Husseini. Prof. Dr. Ahmed Al-Shattura. دكتور سعيد القحطاني. And last but not least, Dr. Hisham bin Abdul Kamil. For now, we will have a 30 minutes break. You can have coffee if you want, and then we will continue with our second session. Thank you all.
Okay, good morning everyone. واضح؟ Okay. Okay, good morning everyone. This is Noor Al-Ajmi, clinical pharmacy resident at Eastern Health Cluster. Before starting, I want to thank you all for attending the third day of this conference. The second session for today will be moderated by Dr. Hatem Al-Qahtani. Dr. Al-Qahtani is an assistant professor, consultant of family and occupational medicine at College of Medicine in Imam Abdurrahman bin Faisal University. In addition, he is designated as civil aviation medical examiner from United States Federal Aviation Administration, USA and Saudi General Authority of Civil Aviation, aviation medical examiner in King Fahd University Hospital. Furthermore, Dr. Al-Qahtani is an assistant program director of occupational medicine fellowship program in College of Medicine at Imam Abdurrahman bin Faisal University. Without further ado, let's welcome Dr. Al-Qahtani.
Thank you so much. Bismillah, assalamu alaikum wa rahmatullahi wa barakatuh. Good morning all. So thank you for this conference, Dr. Maha and all the staff and our colleagues. Today our session is about evaluation of environmental and occupational chemical contamination and health and safety. So we'll talk about three sessions, the first three topics. The first topic is about petrochemical industries toxicity. Please welcome Professor Dr. Abdul Latif Al-Oumi. Dr. Al-Oumi is a lead of toxicology services in Kuwait and toxicologist and emergency medicine senior specialist in Al-Amiri Hospital. So please let us give applause. Okay.
Assalamu alaikum. Thank you very much for this kind invitation. I have the pleasure of talking about probably the most important industry that we have, both Kuwait and Saudi. I have nothing to disclose. There are a few of my objectives that I'm hoping to cover in the 25 minutes I have to present for you. So even though our region takes a small chunk of the world, 5 out of the top 10 countries in this region are oil producers. However, and we have obviously Aramco. Oh, sorry. Okay. Okay. Sorry for this technical difficulty. Inshallah. Okay. Yeah, looks good. As I was saying, even though we take a small chunk of the world, however, 5 out of the top 10 oil producers come from this region. And obviously, Saudi Aramco is the top oil company producer in the world. However, we're less of consumer to petrochemicals. Apart from Saudi, there is, oil consumption, only Saudi is a consumer. So we're mainly oil producers. Now, Kuwait, half of its revenue, governmental revenue, comes from oil, actually 90% of it, and 95% of its exports. Saudi used to be very similar to Kuwait in the governmental revenue. However, recently, the Saudi government have been doing remarkable work in the non-oil revenue for the country. As you can see, it's almost matching the oil revenue. But still, the oil industry comes top of the industries that are in Saudi. Now, our Kuwait Oil Company, as well as Saudi Aramco, they care a lot about the health and safety. We have a hospital for oil industry workers and their family, with ambulances in 10 different sites, with a preventative medicine with annual checkups. Here in Aramco, you have, again, the Johns Hopkins Aramco Healthcare, with a bed capacity of 483 beds. You also have 4 major clinics in the Eastern Province with its own ambulance. In other remote areas, there are multiple contracts with private clinics with their ambulances for the sites that are in the desert. There is an annual sustainability report that Saudi Aramco produces. Those are the Tier 1 process safety events that happened during the years. So we can see that there are incidents of exposures that happen for healthcare, for workers of this industry. One of the most important sectors and departments that have an effective input in the healthcare of their workers is the health, safety, and environment sectors. They do a lot of things, as you can see from the slide. They also ensure that all chemicals have an MSDS, which is the labeling for every single chemical that goes in. They have an input in ordering, choosing the least toxic of chemicals, how they are stored and transported. They also do quite a lot in compulsory training. So about once or twice a year, all oil workers have to undergo some kind of training. They ensure safe work environment by having decontamination areas in their on site, as well as chemical spill kits which contain sodium carbonate, which is soda ash. So what is the composition of crude oil? It's mainly hydrocarbons with some non-hydrocarbon elements as well. And the crude oil goes through quite few processes until it reaches the consumer. The first process is the upstream, which involves the exploration and production of oil, transportation in the midstream, and then the downstream, which is the refining and the petrochemical industry. Now, each step, the workers and the employees can encounter a lot of chemicals that, due to time constraints, I would not be able to go through all of them. The simplest and the first form of oil refining is the fraction distillation, which involves heating the crude oil, and depending on their boiling point, they get separated into different elements. When I interviewed officers of the Health, Safety and Environment Department on the most common hazard they encounter, trauma came first, as well as fire, and then our area of concern, which is the chemical and inhalational injury. This collaborated well with what the National Institute for Occupational Safety and Health in the US, where they demonstrated the majority of injuries for the petrochemical employees are from trauma. However, there is a 6% of exposures that the employees were led to their fatality. This is our last incident in Kuwait, January 2022, where an explosion happened in Mina Al-Ahmadi that resulted in 2 deaths and 10 burn victims. Now, if we look at our area of concern, there were 8 fatalities between the years of 2015 and 16 due to exposure of substances and cardiac arrest. So what are those substances? So there are, as we saw in previous slides, there are multiple, and it's almost impossible to go through them. And each chemical has its different mechanism of toxicity. What the Occupational Safety and Health Administration in the United States, they produced materials on 8 specific topics. And I had to choose the top 4 to discuss them briefly. The first is the hydrocarbon gases and vapors. And there are multiple published documents highlighting this issue. And how the workers get exposed is, if you see the big oil tanks, there is a hatch on the top. And the worker has to go, open this hatch, and then try to test the oil inside those tanks. What happens is when the hatch opens, the fumes and the vapors, gases come out. They have 2 mechanisms of toxicity. Number 1, those gases displace oxygen, leading to asphyxia and either loss of consciousness or death. The other mechanism, due to those products being hydrocarbons, they lead to cardiac sensitization that could lead to cardiac arrhythmia that are usually fatal. They tested the gases that come out when they transport the oil products. And you can see the levels are extremely high when you test just around the transported products. So this is the immediate danger to life and health levels, which the first would be methane. So the level would be 5,000. That's 28 times the level of that could cause immediate danger to life and health. Now, any petrochemical talk has to include hydrogen sulfide. Hydrogen sulfide is found naturally in some oil deposits. It's also produced when trying to clean the pipes with hydrochloric acid. It's also a byproduct when desulfurization of oil. It has a color. It has a rotten egg smell. It's colorless, flammable. It causes irritation. So the first signs and symptoms would be eye and mucous membrane irritation. It has an effect that at certain level, the workers will not have the smell of this rotten egg because of olfactory fatigue. So it gives them a false reassurance. It can cause an immediate knockdown or slaughterhouse effect where the worker could drop dead at taking just 1 or 2 breaths. And that's why we see any employer that goes to the rig, they have to have those monitors, and those are H2S monitors. And there are certain levels that the facility is aware of. At, for example, 10 parts per million, there is a trigger in the area. At 50, the siren in all facility. And this is probably the only incident where the site or supervisor is able to shut down the facility based on this reading without going up to the chain ladder. The workers, as I said, they do 2 annual trainings. One of them is specifically for H2S, and the other includes H2S. At certain levels, H2S can cause different signs and symptoms. Again, I'm not going to go through them, but we can see the odor to begin with, and then you lose the ability to smell the H2S, and then you get the irritation, and at severe high concentration, rapid collapse and death happens. Those are some fatalities that I was able to find. In 1981, this is the only one I found from Aramco. There were 19 employees died from H2S, and the rest are from Kuwait data. And those are public data because they were in the news. And the last incident happened in 2011 in Kuwait, in Min al-Ahmadi. And this is the usual scenario. So H2S, because it's heavier than air, it's mainly found in pits. So those workers went to the pit. Two of them went in. They collapsed. Their friends or their colleagues came to help them, and they ended up collapsing and dying. And this is the classic scenario where H2S happens, as patients keep on collapsing until someone realizes that this is H2S. There are other case reports in the news about local kind of data. So not all H2S cases are public. The other chemical that I'm going to talk about very briefly is hydrochloride or acid. And it's used in high concentration to dissolve the rocks, so oil can be extracted much easier. Hydrofluoric acid has a similar use. An incident happened in October 1987 in Texas, where a crane that was carrying a load dropped its load on a tank full of hydrofluoric acid. It led to 939 patients seeking medical attention. Around 100 of them required hospitalization. Hydrofluoric acid is an irritant, and when testing them, they showed hypocalcemia, which is a classic, presentation of hydrofluoric acid. A chemical that is found in crude oil and is a byproduct of refining process, which is used as a solvent and has been gradually being replaced due to it being an IARC group 1 carcinogenic, leading to hematological cancer, acute myeloid leukemia, and other hematological diseases. It is detected, or if you were to check an employer, you would check urinary phenol to see if this patient was exposed or not. So due to its high carcinogenicity, it has been replaced with toluene, which is found in paints and multiple products that we have even at home. And it has its toxicity as well, usually detected by urinary hippuric acid. It causes neurological signs and symptoms, especially when it's extremely high, like leukoencephalopathy. Anhexane, its chronic inhalation can cause, again, axonopathy, a sign called dying back syndrome, where peripheral neuropathy starts and then goes to an ascending motor deficit and quadriparesis. And this is the chemical that is thought to cause the gasoline neuropathy, as it's available in 3% in the gasoline that we use for our cars. Very briefly about chronic inhalants. Silica is used in multiple places in the industry. They use it in high pump pressures in sandblasting and cleaning equipment, as well as removing the rust and the dirt from the floors using silica in high power pressure. And this can lead to inflammatory response and fibrosis. The next is asbestos, which is not used anymore. However, it's found in the old buildings that some are still there. So when the workers go to take them out, they have a potential to be exposed to asbestos, which leads to lung cancer and pulmonary fibrosis. Now, lead, or in the past, there were leaded petrol and unleaded petrol. So adding lead to petrol used to improve the burning of the gasoline. And that's why it was invented in 1921 by this guy, Thomas Midgley. 2 years after his invention, he had to take time off with symptoms that sounded like lead toxicity. So he took time off to go to Florida to get like fresh air. Now, within this year, 15 of his employees in the factory that produces this lead died, and few others were severely poisoned. And the thought was it was lead poisoning. However, it was so effective that no immediate action was happened until 50 years later. So in 1973, the Environmental Protection Agency issued regulation to reduce lead in gasoline. And not until 1996, where the Clear Air Act banned lead from being in gasoline, to be sold in gasoline. So, as well as lead, this guy also invented freon. So the New Scientist journal called Thomas Midgley the one-man environmental disaster. Now, lead toxicity can cause polyneuropathy, and on severe cases, it can lead to encephalopathy. But unlike the lead that is inorganic, it doesn't demonstrate a lot of hematological abnormalities. And oil industry or petrochemical oil has its effect on the environment. I picked only one due to time constraints, and this is oil spill detection. Our main source of water in this region is desalination of seawater. It takes around 5 years for the water to recirculate in the Arabian Gulf. So oil spills can, it threatens our water security since we don't have a real renewable water supply. This picture is taken in satellite. In 2017, there were 4,900 oil spills, and they covered 13 or almost 14,000 square kilometers. And that's why we have two organizations, the Regional Organization for the Protection of Marine Environment, and then the MEMAC, which ensure the safety of the Gulf Sea. So when oil spills are detected, those boats go to the site, they measure, and they also take sample and try to contain those oil spills.
Dr. Abdul Latif, thank you so much. We have 1 minute.
Okay,
remaining.
this is actually my last slide.
Good. Thank you.
So this is again from Saudi Aramco Sustainability Report. There was one major oil spill in 2021, and Saudi Aramco did a great job. 95% of this oil spill was recovered and reprocessed, and this incident happened in Safaniya oil rig. So it's a big topic, the petrochemical industry toxicity, and this topic cannot be covered in 25 minutes, but I try to give you just points for hopefully for future involvement in this, because this industry is the bread and butter of our country's economy, and we should always maintain it as safe as possible. Thank you very much.
Thank you so much, Prof. Dr. Abdul Latif, for this informative presentation about toxicology in the environment and petrochemical also. So now we will move to another session. Next session, it's about toxicological mass causality events, insight from regional and international incidents. So introduce Dr. Islam Jamaluddin. Welcome, Dr. Islam. Dr. Islam is well-rounded clinician scientist with a solid background and achievement records in pharmacology and also in toxicology, quality and patient safety, teaching, addiction, and long list. Preclinical and clinical research, writing and critique. In addition, he led various change projects with varying strategies and objectives. Current job, Dr. Islam is a quality coordinator and patient safety advisor. Additionally, he is an assistant deputy for laboratories and blood banks and poison control centers in Riyadh in Saudi Arabia. So please welcome Dr. Islam. Welcome, Dr. Islam. The stage is yours. Thank you.
السلام عليكم جميعا. الصوت واضح؟ الناس at the back. I'd like to start by thanking the organization committee for their kind يعني دعوتهم الكريمة وللتنظيم الرائع للمؤتمر الجميل. By choosing this topic, I'm hoping to make it very relevant for the region. The Eastern region is a region that is packed with several chemical industries that involve also the transportation and storage of several chemical substances. And I'm also hoping that it's relevant for the country. The kingdom, of course, is a place where several religious events happen, and of course Hajj is the highlight of them, and also the Umrah. So we have mass gatherings that require our attention, our coordination, and our vigilance in order to, inshallah, avoid occurrence of any mishaps. So the outline of my talk today will cover we'll go through some mass toxicological casualty events. I'll give you some background information about several agents and the way we approach mass toxicological events. Also how the best approach the TMCEs from the medical perspective. There are very useful tools out there that we can utilize. And also lessons learned and how to plan properly for TMCEs. So this is a list of some of the mass toxicological events that happened worldwide. Of course, the most recent, the one that happened in Aqaba, Jordan last June. We all remember that famous cloud with the yellow cloud with the chlorine gas that led to the demise of 13 people and more than 260 injuries. However, the most deadliest one was the one that was recorded in India in 1984, where there was a cyanide gas leak that led to the deaths of more than 3,700 people, and more than 500,000 people were actually affected by this incident. We're going to also delve deep into two other incidents, one that happened in Japan in 1995 and another one that happened in the US in 2005 in South Carolina. And I'm going to tell you the reason why I chose these two events to talk about in more depth. So the most accepted approach and the most widely used approach when training first responders is the toxicological toxidrome approach. So And there are 4 toxidromes that are now widely used to train the first responders to identify, because identifying the causative substance is one of the biggest challenges and also one of the biggest determinants of how successful your recovery process is. So the first toxidrome is the primary respiratory irritant toxidrome. It is caused by substances like chlorine, which is the most famous and most widely used chemical worldwide. It's used in a variety of industries, like, for example, plastic industries. It's in disinfectants. It's used in treatment of sewage, etc. So it's very, very widely used, and one of the most substances that cause also gas spillages, etc. Of course, sulfur dioxide and ammonia are also one of the most famous chemicals that cause such toxidromes, and also phosphagen. However, what distinguishes chlorine, sulfur dioxide, and ammonia is that they are water soluble. So this makes them very irritant. This allows people to be aware of their presence. They cause choking and irritation just from the slightest smell and breath. And this allows people to flee and run away from the scene of the spill. However, the water insoluble, like phosphagen, for example, which is also an industrial chemical and used to be also used in World War I for chemical warfare. It is water insoluble, and this unfortunately doesn't make it detectable early on, but causes late symptoms and late signs of intoxication later on. The second type of toxidrome is the vesicant toxidrome, and from the name you can tell that it's a distinct class of chemical warfare agents used first in World War I, like the nitrogen mustard is the most famous, and also the lewisite and also phosphagen, and it causes severe insults to the eye, the conjunctival cornea. It causes vesicles in the skin and also affects the lungs severely. The third class, of course, is a very famous class, which is the asphyxiants. The most known, of course, is the cyanide and the carbon monoxide, and they cause the famous red asphyxia that we see in post-mortem cases. And these are asphyxiants at the level of the cells. They don't allow the cells to utilize the oxygen that is in the bloodstream, and that leads to also a very famous clinical picture that we commonly see in the ER. It's very common also to see these cases nowadays, since winter is coming. People tend to put wood and burn wood and stay in a tent or something like that, and that's when we see the carbon monoxide poisoning, which is very famously also mixed up with food poisoning, because people present with nausea and vomiting, projectile vomiting. So a lot of times we saw in the ER that these patients come to us because they're referred to us as food poisoning cases, and then when you take proper history and do the proper examination and measure the blood gases, we find that it's actually carbon monoxide. The fourth and last toxidrome is the choline esterase inhibition toxidrome. Some of our colleagues yesterday talked about the famous sludge, the paralysis, the seizures, and coma. This is the typical frothing that we see in these cases, and of course the very famous pinpoint pupils that we all know about. And of course, one of the most famous substances, of course, are the organophosphate compounds, and also the carbamates, and the serine and VX compounds, which are, of course, now used as in chemical warfare. Serine was initially developed as an insecticide, like organophosphates, but then it was found to be an ideal weapon for chemical warfare because it has no smell, it's colorless, so it can deceive people at the sites where it's deployed. So the first incident that I'm gonna delve deep into is the one that happened in Graniteville, South Carolina, US. This was in 2005. This was a leak that occurred. This was a train that was carrying chlorine into that town. It actually bumped into another train that was parking at that site, and it led to venting of 80 tons of chlorine gas. Luckily, the casualties were only 9 deaths, and the number of people that were injured were 520, which is a very, very small number. Because actually the incident occurred at 2 a.m. in the morning, so most people were sheltered in their homes, and the exposure was limited. But what was interesting is that the first call took place after 1 minute of the incident. And another call actually mentioned the compound. So they said it's a chlorine leak. So there was no brainstorming. It was very clear. Everything was evident. And the response was so fast that the fire marshal went there within 6 minutes. And he started setting a perimeter within 13 minutes. Very, very fast, yet you will see later that it was very, there were a lot of issues that led to inefficiencies in decision making. So fast responses doesn't mean necessarily that the rest, there's a huge cascade of decisions that need to be made, and they need to be efficient, and there needs to be more coordination. And we're going to talk about that later. There was also a reverse 911 initiated, which for you, it's a system in the USA and Canada where actually 911 starts to send messages to people instead of receiving messages, and starts to give them instructions in what to do. So this was already initiated, all of that within like 15 minutes. The other incident, and the reason I chose these 2 incidents is that one was accidental, the other one was premeditated, and also the contrast in substances. And the last reason that I chose these 2 incidents is that they are very well studied. There's a lot of documentation, a lot of lessons learned from these 2 incidents that I'm going to talk about later. So the second incident was the famous attack that happened with the sarin attack that happened in Japan in 1995. And it led to, it was a premeditated attack in 15 different sites, synchronized at the same time. There was a cult called Doomsday Cult in Japan. They had these sarin bags filled with liquid sarin, and they punctured them with the tip of umbrellas, and they released sarin in these sites, and there were more than 5,500 injuries and more than 13 deaths. And mind you that Japan is a very well prepared country for events, because it's an earthquake country, so they have very rigorous planning, but you'll see that there was still a lot of deficiencies when these plans were executed for chemical. So they were prepared for natural disasters, but they weren't very much prepared for other kinds of disasters at the time. And mind you that also there was another attack that happened a few months earlier in another city in Japan called Matsumoto in 1994. So this was, they had like an early warning of these kind of attacks, yet they could have coordinated things better. More than 139 healthcare workers were also intoxicated, and this represents about 10% of the people that responded to that incident. In order to attend for people at these sites after a mass casualty event, we need to first be mindful of the protection of the first responders. And in these situations, the ideal response, of course, we have different types of hazmat suits, as you can see. The first one is the one that is used for extremely dangerous situations. It's used also if there's radiation, risk of radiation contamination, risk of biological contamination. But it's, as you can see, it's not very maneuverable. It's mainly for people to go in, maybe to scoop and remove people, but not to try to introduce treatments or first aid. And also if you want to take samples from that area. And so as level B, it's also the same. The gloves, you can see they cannot be used, for example, to insert a cannula, to give IV, to intubate a patient. And so in the ideal situation, we will, our first responders for chemical events would use the level C hazmat suits in order to protect themselves and at the same time be easily maneuverable. They don't get tired, they can work for long hours, but in the first two suits, there is a risk of dehydration and exhaustion in these suits because they're very, very well insulated. So what should we do when we are encountering this situation? As I mentioned, the first thing is to remove the victims to the fresh air. Initial evaluation, the typical ABC that we all know about is crucial. And of course, determine the toxidrome. Why determine the toxidrome? Because according to toxidrome, if it's an asphyxiant or if it's one of the organophosphate toxidromes, then we can have antidotes. So this will change a little bit the way we approach the patient. If it's of one of the other toxidromes, the vesicant or the irritant, then there's no introduction of antidotes. So first we have to find out, is the chemical substance known or not? And if it's known, then we have to determine whether the contamination is needed or not. And that depends on several factors like the type of contamination, whether it's visible or not, whether there are signs or symptoms or not. And it's very, very important, and I very much emphasize using resources. Use the available resources. Don't try to improvise, okay? And I'll talk about the available resources in details later on. So, talk to your regional PCC. All PCCs throughout all the incidents worldwide, they've shown to be one of the most effective tools that you can have in your region. And also there's something called Wiser that I'll talk about later that is very interesting and very useful tool. And so if the substance is known and the contamination is needed, then you start to decontaminate, and then I'll talk more in detail about the decontamination techniques. If the substance is unknown, attempt to identify the substance. And again, use the resources. Use the tools that you have. You have the MSDS data sheets. You have the PCC that you have, like the one, the MEM, for example, regional PCC, and the rest of the PCCs throughout the kingdom. We have 10 now. And there's also the Wiser and the ChemList, which are also very, very useful resources, and they are publicly available for anyone. So the ideal decontamination scenario was that you set a decontamination site at the spill site. That's the ideal situation, similar to this one. And it should be, if performed at the hospital, it should be performed also outside the hospital premises. And the reason is, many experiences have shown that hospitals are actually, the ventilation in hospitals is not ideal for decontaminating chemical spills. And it actually, there's a high incidence of secondary contamination of the staff working in hospitals. So ideally, you should set up a perimeter like this, either at the site of the spill or outside the hospital where these patients are going to be admitted. And of course, the people that are that need to wear the PPEs are the people that will be the first responders. I mean, are the ones that will be attending to the site. But the responders at the hospital, they don't have to be wearing the same type C PPE if the patients have been well decontaminated. Decontamination technique, I can't really tell you how much important it is. I myself worked in a PCC for decades, and we used to decontaminate the patients all the time, etc. And we of course know how important it is. But I witnessed it first eye when I received a patient that was referred to us from another hospital. He was found in the field. He was a farmer. He was found in the field, suffering from the typical sludge and the twitches and all the signs of organophosphate poisoning, and the doctor that attended to that patient was good enough to identify that this is OP, okay? And he started administering atropine, and he started administering the Oxime, and the patient was not improving. Improvement was very transient. And then he just intubated the patient, referred him to us at the Poison Control Center, and he didn't have much of history. And then when I looked at the patient, and I found that he was still wearing his clothes, and there was a very weird smell. And I found that all his clothes were very soaked, but the back of his clothes were soaked with organophosphate compound. And of course, so we decontaminated him very well, and then we started administering the treatment. He started responding very well. So it was very remarkable how the decontamination was very effective in changing the course of the disease, of the problem. And then when we took the history from the patient after he recovered, he said that he was actually spraying OP, the organophosphate compound, in the field, and it was leaking. So there was like a container that was leaking on his clothes, and actually he never ingested organophosphate. All the toxicity signs were just from skin absorption. So this is very important. It's very important to do the decontamination properly. Don't take the clothes the typical way and rub it through on the face and eyes. This causes further absorption of the contaminant. So disrobing through cutting the clothes is very important. And also using the dry decontamination, which is sponges similar to this one here, that you can use in areas where you can see that there's visible contamination. This is then followed by the wet decontamination. And wet decontamination also, there are two types. There's the gross decontamination, which can be done for large population of people, preferably at the site of the incident. As you can see here, these fire trucks are the ones that are doing the gross decontamination. They're doing like using high volume of water, low pressure, that people can just walk through them, do the gross decontamination. And then later, for those that are showing still signs of big exposure, you can do something called the technical decontamination, which is here. You can see it's more specific and go into the creases and do it in a more thorough way. So what are the useful tools? Here we have, of course, the very famous 937. It's a very useful tool. Please use it if you encounter any chemical substance that you are not aware of, or you're suspecting that there is a chemical substance exposure. We have also the OTAR system, which is an online system for submitting of samples. So you can now put a request online and then send your sample to the regional FTC, the Forensic Toxicology Center. The regional FTCs have very, very well qualified medical toxicologists that will be key in informing you what to do and how to address the cases if you meet any. And then there is also the Wiser app that I'm going to show you in a second. So the Wiser app is the wireless information system for emergency responders. It's developed by the US government. It's available for everyone. You can all download it on your cell phones. It's very useful. It has many resources like tutorial videos on how to set a perimeter, how to do proper decontamination. It also gives you details and has guidebooks for the different substances and how to treat them. Like, for example, here you can search chlorine. It will give you pre-hospital management of these cases, and also in the hospital and what to do, how to dispose of these cases. Here also, background information, treatment options, how to handle the patients, the different levels of management at the different hospital sites, and how to do the proper, This is another very cool feature in this app, is that you can actually, it asks you about the type of spill. For example, if it's a rail tank, it's a truck, whatever, and then it asks you about the circumference of the spill. And then it can use your location, asks you about the direction of the wind, okay? And it can use your location. For example, here I tried it in Riyadh, as you can see here, and it can tell you actually the circumference of the area where you can use or set as a perimeter for safety of the people. So it has many cool features. I advise you to try it. It's very important. So what are the lessons learned?
Dr.
How many
Islam,
minutes?
just only 1 minute remaining.
Sorry?
1 minute remaining.
1 minute, okay. This is the most important part. So what are the lessons learned? Luckily, we have a plethora of agencies that would be involved if, God forbid, such chemical events happen. This is just an example of the different agencies. This is not a typo, okay? I didn't put communication 3 times by mistake. I just meant to really emphasize how important communication is. This is always shown to be the major pitfall when dealing with such issues and the incoordination between the different agencies. So we need to really highlight the importance of that. So what causes the problem with communication? First of all, counting on, for example, cell phones. Cell phones are the first things that drop during these, because cell phones are just programmed to only accept 25% surge in phone calls. But if that percentage is more than 25, all the cell phones will drop. So we have to have landlines, count on landlines and also radio frequencies. The problem also with communication is the difference in culture between agencies. If you don't have clear plans, you don't have hierarchy, who makes decisions. So it's very important to have that ironed out. Also, there's a very famous problem with chemical exposures is the silent hour, which is there's an hour, sometimes 2 and 3, that pass by and nobody knows what's going on, nobody identifies what the chemical is, and this is very, very crucial, and it really leads to a lot of casualties. Responders, for example, in the US, although they attended to the site very early, but they could not quickly identify the hazardous substance or the proper procedure. The railway company faxed the police or the fire department that this train is carrying chlorine, but they did not provide them with what to do, how to handle it. They should have been equipped with this. The fire department did not seek industry resources to identify emergency and evacuation procedures. Basically, they told the people to evacuate, they told them run. That's the only instruction that they gave them, which is not very organized. For the incident in Japan, the Japanese government did not have any prior comprehensive plan for chemical disaster. They had it for other kinds of disasters. No plan for on-site decontamination. Most people that, as I mentioned, a lot of the healthcare providers went there, they already got intoxicated because they weren't ready. Triage was not performed well. A lot of cases were said that they were mild cases, but then when they were sent to the hospital or dismissed, they were turned to become even moderate or even severe cases. And as I mentioned, when the medical technicians arrived, a majority of victims have departed on their own. It was very surprising to know that only 7% of the victims arrived by ambulance, and all the rest either arrived by taxi or arrived walking to the nearest hospital. This is the last slide. Hospital emergency department. It's very important to have information about the causative material. For example, one of the things that happened also is that one train continued its journey for more than an hour. It was dispersing sarin throughout more than 10 stations. The police, they identified sarin after 3 hours. There's no information that was distributed directly to the hospitals on how to handle this. So this is just an example of the issues that happen. There are also the well-worried patients, which are people that are worried that they don't have any problem, but they just heard that there is sarin dispersed, and these people actually overwhelmed the hospitals 4 times more than the people that were involved in the incident. So this is just to give you an idea about how to handle such situations. It's very important to have an organization structure, proper communication, maintain emergency equipment, and have a surge capacity plan, and also train the staff, and do all these drills, and of course periodic testing and improvement, and assess risk very well, especially in areas that are industrial, like the eastern region, for example. The town in Graniteville, they were having chlorine trains going through every day, but people didn't know. So it's very important to assess risk and orient the public so that they can be of help. Thank you very much for your attention, and sorry for taking.
Thank you, Dr. Thank you, Dr. Islam, for this great talk. So we know the time is very narrow, so we wanted to move to the next session. Next session is about the current environmental risk of polyfluoryl alkyl substance and their widespread across the Middle East. So the speaker is Dr. Saif Al-Harthi. Dr. Saif Al-Harthi, he is the head of the Occupational Safety and Health Unit and Deputy Director of Toxicology and Forensic Sciences Unit, member in Experimental Animal Unit and Conference Committees. So welcome for Dr. Saeed. Sorry, Dr. Saif. تحملنا, time is very short. Huh?
Thank you very much. Assalamu alaikum. First, I would like to thank Dr. Hatem for the introduction. And honestly, before starting my talk, I would like to say something that it's a great opportunity and a great honor and pleasure to be here witnessing this very great scientific conference and valuable event directed by Dr. Maha Mazroor and her great team, Dr. Ahmed Al-Anizi, and I'm sure the other staff. They've been working day and night to come up with this great conference. So my talk today is about the environment, and as you know, environment is very important, and the reason is that we all are part of that, part of this environment. So I'm here to bring a very specific topic, specific chemicals that have been the hot and recent chemicals topic they've been talking about a lot recently, and this chemical contaminated the environment. They have been showing a lot of toxicity. They have been showing a lot of damages, and honestly, some scientists, they're saying these chemical, they call them the forever chemical, and that's why, because these chemical last forever, and because they last for very, very long time. I will show you the half-life of this chemical once they're released to the environment. Also, some scientists saying that these chemicals are everywhere. And that's why I'm here, honestly, to increase the awareness of the scientists, the researcher, and also the community to pay attention to this kind of chemical. So let me introduce you to the chemical. They are under the family name called PFAS, perfluoroalkyl substances, or polyfluoroalkyl substances. So what is PFAS? PFAS is definitely a man-made or synthetic chemical, and they are, if we're talking about the size of the chemical, it depends on the number of carbons. They're usually from 3 to 15 or 16 carbons, and they have additional group, as is showing in the red circle. This additional group added, and you can see they are functional group, and they are hydrophilic. This chemical also, the different here, and why they call it poly or perfluorinated chemical, because if you look at the structure, you see the hydrogen-carbon bond, the hydrogen atom replaced by fluorine. And sometimes, or some members of this family, you see the hydrogen or the whole structure totally replaced by fluorine, and that's why they call it perfluoro, or maybe partially replaced by fluorine, and that's why they call it polyfluorinated chemical. This table is to show you some members of this family, PFAS, and they classify it based on the number of the carbons and also based on the additional group. And if I ask how many chemicals do you think under this chemical or under this family, actually there are 7,000 chemicals under this family. And the problem is that, or let me tell you very bad news, that only 2 chemicals among these 7 very well studied. So that's a really, really sad news, and it's good for the toxicologists to get to work and dive into this family and see or investigate the toxicity of the members of PFAS. The chemical properties of PFAS is, so once these chemicals released to the environment, they are very persistent, which means that these chemicals are very stable and they can last for very long time. Also, they are very potential, highly toxic based on the, some studies and investigations. And there is a very unique thing behind this chemical is that the carbon-fluorine bond. The carbon-fluorine bond has a very unique features. They are very short bond, and the fluorine has, as you know in the chemistry class, it has a very high electronegativity. This high electronegativity makes the chemical very stable and lasts for a long time. Also, these chemicals are resistant, oil and water resistance. So if you look at this graph, you see the carbon-fluorine bond needs a lot of energy in order to dissociate the chemical. Okay. Let's see from where this chemical come from and a little bit history behind the presence of PFAS. So they discovered this chemical in 1930s, and it was by accident. One of the chemists worked in the lab, and he dropped the chemical on his shoe, and he found out that this chemical doesn't, makes the shoe wet, and he was like, this chemical are water resistant. Then from there, they start to dig inside the chemical, and they found out that it's good to be used in a lot of products. So in 1940s, they, as I said, they start to use this chemical in the commercial products. Then in 1956, the 3M, it's a very company, one of the most company that produce this chemical. They came up with the Scotch Guard. As you know, this kind of spray, when you spray on in the sofa or on the couch or on your clothes, so if you pour the water to the sofa, you see that it doesn't mix with the sofa. And you see sometimes in the advertising that the advertising the sofa is good because, as you see, you cannot, if you pour the water, it doesn't mix. Actually, that because of the PFAS, because this chemical, like as I mentioned previously, oil and water resistant. Then, year after year, they have been using the chemical in a lot of products. And in 1970s, there is a guy, his name is Travis. He kind of had the feeling that this chemical could be in the human. And he actually the first one who discovered the detectable level of this chemical in the serum. Then from that, everything it changed. The scientists start to create a lot of instruments in order to detect the level of this chemical. So in 1990s, there were a lot of sophisticated instruments were created in order to detect the very low concentration of this chemical. And then in 2000, what started there, the awareness of the people, they find out that these chemicals are toxic. The DuPont and 3M, as I mentioned, these are two very famous companies. They create this chemical, and they made the products from this chemical. They stopped and phased out the production, and then the regulation, the researchers, scientists start to pay attention to these chemicals. So what are the sources of PFAS? As I mentioned, that they've been used in a lot of products, maybe about more than 500 products. And so definitely the drinking water, for example, could be a source of these chemicals because they found out that these chemicals have been released inside the drinking water. And I remember that when I was doing my PhD in New York in 2014, my mentor came to me and she said, hey, there is a new chemical released in the New York drinking water we need to do your project on. So I was doing the neurotoxicity to see if these chemicals are neurotoxic. So drinking water is very important and is one of the, definitely, if it gets contaminated with PFAS, so it's one of the sources. You know, also in the kitchen appliance, you can name it. There are a lot of product in the kitchen made of PFAS, and the personal care product, fire extinguish foam, some foods like the fish, because these chemicals, as I said, they release into the water, so the fish there have it, and also the livestock. The food packaging. The food packaging, one of the example is you see the popcorn in the bag. The bag popcorn, they put it in the microwave to cook it there, and that's bag from inside it coated with another. You can see the layer, like oily layer, that's made of the PFAS. Okay, so this is the U.S. map, and just to make sure that you don't confuse, this is not COVID-19 cases. These are the PFAS that distributed in the United States. And as you see, the blue dot represents the drinking water contaminated with this chemical. And the purple dot, it represents the military sites that contaminated with PFAS. The orange one, just unknown sites also contaminated with the PFAS. Also, China, they did the investigation and investigated the water source, the drinking water source. They investigate more than 500, and they found detectable levels of PFAS as well. As you see in the map, there are several types of PFAS there. They detected in the drinking water. So I'm sure that most, or maybe all of you, trying to ask, what about the Arab region? We need to see the map here. Well, this is another sad news that when I trying to find out detectable level of this chemical in our region, I found zero. Just to be honest, just a couple of papers. For example, Saudi Arabia, I just found 2 papers, one in the Red Sea. They detect some levels in Red Sea. And also the same group, they did another study on the fish, and they found detectable level in the fish. Some paper in Jordan, they found some level in the cow and in the milk, also in Egypt and Lebanon. That's it. So that's a lot of, issue, because we need to know how to regulate this chemical. We need to know the level of this chemical in everywhere in our countries, in our cities, in our, sources of life. Okay. So what happened regarding to the regulation, I remember that 2 years ago, I was I attended one of the meetings regarding to regulate and discuss the PFAS. And that meeting attended by, federal agencies, the US FDA, the US EPA, the CDC, CIRCLA, and all organizations who those interested in, regulate the chemicals in the environment and trying to pay attention to the environment. And I remember that every single representative, they were like, we have a very big knowledge gap here and very limited data we need to fill out, because they don't know about the toxicity of these chemicals. They don't know how they behave. So that's a big issue. The EPA, they set the limit up to 400 and 200 pbt. Then they found out this level also caused toxicity. Then they lowered the limit up to 70 ppt. And nowadays, I was looking at the website of EPA. They actually still doubt this level. And there is a lot of issue made by some researchers and scientists saying that this level could be also not safe. Some organization, they lower the level to 20 ppt, but still there is a controversial issues about the level and how to regulate this chemical. So how are we exposed to the chemical? 4 minutes? Okay. How to expose this chemical, as I mentioned, the main routes is the food, drinking water, and the inhalation. So we need to try to to avoid these kind of sources if we kind of doubt it contaminated with this chemical. And definitely we need help from some companies who use this chemical and use it in the products. The ADME of the chemical is that they are rapidly absorbed once they insert the body. They are transcirculate, binding to albumin. And the most important point here I want to show is that the half-life of this chemical. Once this chemical inserts the human body, they last for 5 years, 4 to 5 years. That's the half-life. So you need 10 years to get rid of this chemical. And imagine the acetaminophen has the half-life of the acetaminophen is 4 hours, and it causes a lot of trouble if you miss the dose of the acetaminophen. How about this chemical lasting in your body for long time? And on the top of that, you really don't know if you're exposed to this chemical every day, since they've been used in a lot of products. The toxicity, you can name it. They've been toxic and causing trouble in every single organ. They are endocrine disruptor, and interestingly, they lower the efficacy of the antibodies. If you got vaccinated, they sometimes lower the effective of the antibody because they are carcinogenic, they are genotoxic, because they can transport from the maternal to the fetal through the placenta. Also, they are oxidative stress. They cause oxidative stress. And this is a study done by me and my mentor, Dr. Diane Hardy, to study the role of the NERV2 knockout. The role of the NERV2, which is NERV2, you know, it's a protein responsible for producing the antioxidant. We want to know if the presence of NERV2 is important to counteract the effect of this chemical or not. I'm not just show very quick data. This is the TEM, and this is the astrocyte, the control, as you see, and we see there normal, healthy mitochondria. And the bottom, we can see the treated astrocyte, and it looks very messy there. And as you see, the mitochondria is now very damaged, and there are a lot of alteration. Also, I did in vivo study, and this is the liver. And as you see, the chemical causing fibrosis. This is trichromostain. Trichromostain is to show if there is fibrosis caused by chemicals or not. The blue color is the indicator of the presence of fibrosis. Another slides or another figures here, we can see the dead cells. The brown, they are apoptotic cells. This is the tunnel assay to show you the apoptosis in the cells. And finally, we definitely want to ask, what should we do? As I mentioned previously, that we need to work together. We need the organization, we need the scientist, researcher, all these people to work together in order to regulate, to investigate, to detect and study the toxicity, the presence, the level of this chemical in our life. And as I told you before, we have really nothing about him. And that's a really problem. So also we can't just try to avoid any source the sources I mentioned previously. We're trying to avoid them as much as we could. And honestly, the glass, it sounds like the safest tool so far. And I'm glad if you look at the tables, we can see the glass bottle. I'm so happy with that. So that's it. I would like, thank you for listening. And yeah, thank you.
Thank you so much, Dr. Saif, for this interesting topic. Now we have Dr. Al-Haqiqa, Dr.
So before starting the discussion
Dr. Abdul
panel,
Latif. He will leave. He has international flights. So we will move to part.
So before starting the discussion panel, let's welcome Dr. Maha Al-Mazrou and Dr. Ahmed Al-Anazi to thank the speaker of this session. Okay. The moderator of this session, Dr. Hatem Al-Qahtani. The speaker, the first one, Professor Dr. Abdul Latif Al-Aoumi. أنا موجود. الدكتور إسلام جمال الدين. And the last speaker of this session, Dr. Saif Al-Harthi. الدكتور ناصر القحطاني.
اسمحوا لنا نكرم الأعضاء اللجنة الاستشارية اللي ما كانوا معنا بالأمس. دكتور ناصر القحطاني. دكتور ناصر تسلم، الله يسعدك يا رب.
مزيدا من التقدم إن شاء الله.
الله يسعدك يا دكتور، تسلم. دكتور صلاح المنشاوي، دكتور العبيد صلاح المنشاوي. رئيس اللجنة المشرف العلمي للجنة العلمية الدكتور علي القحطاني.
Okay.
Okay, thank you so much for organization. About our sessions. Okay, let us open the questions from the audience about our sessions, the occupational and environmental contaminants. تفضل يا دكتور.
Bismillah. Dr. Islam, I have a question for you. You covered the acute exposure and how you
Not really.
Dr. Islam, you covered how to decontaminate, handle disaster.
We didn't hear you, Dr. Saeed. Take this mic. You can ask.
Yes, Dr. Islam, sorry for that. You actually covered very well how to handle the acute big disaster and how to take an action. What about the big disaster that is going on without us being known that it's occurring? Without us being known that it's happening. Like Dr. Saif also covered like a new chemicals that we could actually expose to them. It does not show that, I mean, the acute response that will actually make us to pay enough attention. So what should we do in this case? They are chemical disaster, but they are not obvious. We don't have enough data or like people dying from those chemicals.
That's actually that's $1 million question. The problem is when you look at the literature, when you study all the mass casualty events, you will always find, no matter how developed the country is, no matter even how many times it has been exposed to these events, no matter how good the infrastructure is, there will still be pitfalls, deficiencies. From what, maybe since I'm a medical toxicologist, so maybe I'm a bit biased, but what I've noticed is that there's not enough medical toxicologists in different parts of the world, so unfortunately you cannot deploy them as first responders. So usually they, and there's always like a kind of a gap. As I mentioned, there's the silent hour where nobody knows what to do and they usually get consulted later. For example, in the attack in Japan, the fire department used detectors to detect what the substance is, and the detectors actually didn't have sarin in their database. And they actually misidentified the substance as methyl isocyanide, okay? And this led to chaos and led to more people getting intoxicated, etc., until they called the regional PCC, and then they started telling them, no, this toxidrome doesn't go with the cyanide. So I think focusing more on this specialty, having more medical toxicologists, also deploying them during these situations might be useful. The other thing is there's also something called in-exposure fatigue. Most first responders, they're not specialized in chemical warfare. So they might go every year or every 6 months to encounter something like that. So their knowledge is not refreshed, they're not getting enough drills. So this is something that also needs to be addressed when we're planning for such events. I hope I answered your question.
I have a related question to the dust that we are suffering from here in the Middle East. How could we reduce the amount of dust that people been inhaled?
As I understand your question regarding the dust, is that right? As the prevention measures, is that right, about the community? As the national levels, this is what you mean? Yeah.
What is the question? Okay. So, well, it's really hard to do that. For example, I give you an example. There was a contamination regarding to the dust because of the wind. What the wind did at that time, they made it one of the chemicals make an issue in the United States. When they track the chemical backward, they found it comes from Canada. So the wind plays a role here, and there are a lot of cofactors playing roles in distributing the chemicals, especially those chemicals that contaminate the air or the dust. So I believe it needs a lot of work here because it's very hard to control the wind. It's very hard to control the dust as well. And if you look in the history, you will see the issue that happened in London when result from the direction of the wind. And what happened that, in London a long time ago, they used to rely on the chimney to get the warm. And the wind was, instead of taking the coals or the fog to the up of the air, they kept it inside the city. And at that time, a lot of people died, especially those who have asthma or problem with the lung. So unfortunately, this kind of thing happens sometime, you don't know, but we learn the lesson from that. We should prepare ourselves based on the previous crisis. And that's what happened also, I mean, in Jeddah regarding to the water, that's also considered contamination, but that's not the air, that's the water issue. So this kind of thing has to be studies, relies on the previous crisis. Also, we have to, the risk assessment plays a very important role here. I mean, we're trying to do as a toxicologist as much we could, also with the safety, with the risk assessment to. Okay, that's it. I thought to stop talking. So I was still, okay, thank you.
I have.
Okay, last question. Go ahead.
It's to Dr. Saif.
Dr. Saif.
Dr. Saif, I really appreciate your awareness about this compound, PFAS, and I got scared.
Yeah.
I really got scared. I mean, it's everywhere.
It is.
It is everywhere. It is even in our children popcorn packaging.
Exactly.
So it's my question. I mean, so we are a researcher, and we want to do something beneficial. So there is 2 points. I'm just wondering if you are going to pursue it. The first thing, using social media or whatever is the channel to aware the families, all of the people in Saudi Arabia, because as I am seeing, it is toxic to most of the organs. The next thing, are there any plan to make a recommendation for the government customs to screen against this compound and to prevent it from entering Saudi Arabia and to.
Okay, so if you look here in this conference, is one of the point that connect me to the audience, and I send a message, right? So this is one of the media, the social, or one of the point, the networking that we really need to take care of. in order to communicate with, let's say, internationally, or they communicate with the scientists. Because sometimes the scientists, they have a different look than the community, right? They trying to see and search for where the toxic come from. And sometimes maybe you cannot, the thing not happen yet, but they trying, like Travis et al., he kind of sense and suggest these chemical might be inside the human body because they've been used in the product. Okay, so how to advertise, or how to increase the awareness? We have first to use the media. We have to use this kind of events. We have to communicate with the people outside, not just keep our collaboration inside. We need to communicate internationally. These points, the scientific points, is very important to connect the message from scientists to another one in order to be sent out to the community. Sometimes sending a message like this, I cannot say this in front of the people because I said it here because I'm sure that I'm in front of scientist people. I cannot say it to the regular people because they're gonna get scared. We need to, before that, to know how to regulate, because I said the agencies, the scientists, the researcher, all these pillars, they can do something, but at the same time, they have to be really aware of what is going on. Not just focus on one area. We have to communicate with the scientists around the world. We have to, now we have the internet, the online. That's a very good to get the, to get whatever we want very easily, to search for anything we want very easily. And you have a lot of website journals that showed the updated issue regarding to the toxicology. Those conferences happening every year, and it's very important. For example, the Society of Toxicology in the United States, when I go there, I trying to take a very quick round to see what's the new. And this is one of the catch-up, So it's, yes, very hard to control, but it's not impossible. And at the same time, once we heard about it, we need to make a very quick action. Not just like listen to it or ignore it, or like trying to, this kind of thing has to be work very hard. And they see the United States, they are struggling so far. They started like since 2000, and so far it has been like 20 years, but they're still trying to find out. Because, this kind of thing rely definitely on the science, on the scientists, on the researchers. So that has to be supported very well in order to build a very strong database, or very strong centers to search very well about what is going on in the environment.
Dr. Saif? Thank you so much. Okay, we have the last question.
Can I have it?
I think the time is out. Okay, go
My
ahead.
question to Dr. Saif, as you mentioned that PFAS is everywhere and toxify various organs, and is there any specific concentration or incubation time to start developing signs and symptoms?
Okay, no, I don't know actually, because first of all, the half-life of this chemical different from person to person and depends on the chemical. I mentioned that the half-life is 4 years, but if you look at the animal, for example, the mice I was working with, the half-life is 7 days. So it depends on the, the toxicokinetic of every single person. I can say that human don't expose to this chemical at very high level. Especially, there are specific populations, especially those who work with inside the companies. Those companies deal with the PFAS, or someone like me working with the PFAS. I'm not sure. I haven't tested myself. So those, for example, they might have a high level of the concentration of this chemical, but I'm not sure if at which level they might cause a problem, because the half-life, as I said, very huge, and we cannot know how much you exposed to this chemical at that day, how much you exposed to them on that day. So that's why we need to set up a lot of research on this. Okay? Thank you.
Thank you very much.
Okay, so at the end, first of all, I would like to thank the scientific committee to expose this topic of this session. Actually, all of us are exposed to environmental or occupational hazard if we don't know sometime. Especially here in Eastern region, as you know, the 75% of industries in the Eastern region in Saudi Arabia. So thank you for this topic. Thank you for our speakers about these nice topics. So thank you all.
Okay, thank you all for attending this session until its end. Now we will have a break for 1 hour, then we will start the third session for today.
السلام عليكم. بسم الله رح نبدأ الجلسة. Hello everyone, I'm Munira Khalid Al-Kleb and I will present and I will introduce our last session about pharmacotoxicological advancement in oncology therapies and the clinical outcome research by Dr. Nasser Al-Qahtani, who have a PhD in health policies and outcome research. He is the director for healthcare ecosystem and strategy in Roche products, and also he is an adjunct assistant professor at Al Faisal University. Let's welcome our Dr. Nasser Al-Qahtani.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساكم جميعا بكل خير. Thank you so much, the organizing committee, actually, for inviting us and for the fruitful hospitality that we received during the last couple of days. Our session is, I know it's a late session, it's after the lunch, but I want everybody actually to draw full attention to the unique lectures that we will deliver in this session. So we'll actually introduce our first speaker, Dr. Abdurrahman Al-Nizi. Dr. Al-Nizi, he pursued his American board certified oncology pharmacist. He's actually he got actually a certification also from the Saudi board as a hematology oncology pharmacist. He's working now as a clinical assistant professor at Noura bin Abdurrahman University. Also, he's hematology and oncology clinical pharmacist at King Abdullah bin Abdul Aziz University Hospital at the same university. Please share with me welcoming Dr. Al-Nizi.
Assalamu alaikum. Good afternoon all. First of all, I would like to thank the organization committee and the scientific committee for their great organization and also for their kind invitation. Inshallah, I'm going to talk about one of the most trending topic in the oncology field, which is the immunotherapy and exactly immune checkpoint inhibitors in treatment of cancer patient. Specifically, I'm going to talk about the toxicity related to these agents and their clinical management. So let's start with the outline. We will have a brief introduction about these agents. Then we will talk about the toxicity and their clinical management based on the international guideline, ASCO and NCCN. So immunotherapy now becoming a trending modality of treatment in cancer patients, and now one of these modalities is using immune checkpoint inhibitor. These agents or this group of immunotherapy now becoming or increasing the overall survival in cancer patients. So the first medication was approved from the US FDA, which is ipilimumab, was in 2011, recently within 10 or 11 years. The mechanism of action of this agent is by increasing the intrinsic anti-tumor immunity in the human body. And they are working by blocking the intrinsic down regulator of immunity. Their target receptor or ligand is the CTLA4 and PD1, and the ligand of the programmed cell death, which is PDL1. So we have two receptors and one ligand. This is an example of the mechanism of action of the programmed cell death and their ligand, as we can see here. As we can see in the picture in the left, this is the presence of T cell lymphocyte. Now the T cell cannot attack the tumor cell because the tumor cell can escape from this T cell by binding of the ligand to the PD-1. So the PD-1 is a down-regulator of immunity. The mechanism of this, the immune checkpoint inhibitor now is to targeting this receptor, which is the PD-1. By blocking the PD-1 or by blocking the ligand of this receptor, the immune system can attack the tumor cell and destroy it. This is an example of the currently available immune checkpoint inhibitor in the market. We have with several targets as we describe it, and they have several approved indication. We have the ipilimumab, which was the first immune checkpoint inhibitor approved by the FDA, which targets CTLA-4 and indicated for several cancer management such as melanoma, microsatellite instability and deficient mismatch repair colorectal cancer, and renal cell carcinoma. Also, we have nivolumab, which targeting PD-1, and we have also pembrolizumab targeting the PD-1. They have almost similar indication with some extra indication with pembrolizumab. Also, we have atezolizumab, the third one from the bottom, which targeting the ligand of the receptor, which is PD-L1 inhibitor. This is the currently available agent in the market, and currently in the kingdom we are start using these agents since almost 4 to 5 years. So moving to the toxicity of these agents, as I described earlier, that this agent increasing or enhancing the immunity of the human body. So by increasing the activity of the immune system, the checkpoint inhibitor may have a specific side effect or inflammatory side effect, which known as immune-related adverse event. This immune-related adverse event can occur at any organ in the human body, but however, the most commonly involved is the skin, GI tract, endocrine glands, and liver. A meta-analysis comparing the PD-1 inhibitor, Nivo and Pembro, comparing to traditional or conventional therapy or chemotherapy in treatment of cancer patient, they found that the immune checkpoint inhibitor generally have a fewer adverse event comparing to the conventional chemotherapy. However, the type of this adverse event is different than the traditional or the conventional chemotherapy adverse event. They are more immune related, mimicking the autoimmune disease. So this is just an example of the organ or the inflammatory or the adverse event can occur after the immune checkpoint inhibitors. So the exact mechanism or the exact pathophysiologic mechanism is still under investigation, not fully understood. So there are several mechanisms or contributing factors enhancing the occurrence of this adverse event, such as autoantibodies, and autoantibodies actually is the most commonly studied contributing factor related to the incidence of immune checkpoint inhibitor. Also, we have T-cell infiltration, increase the level of interleukin, and other inflammatory cytokine. And in regard to autoantibodies, in some studies of patients treating with immune checkpoint, the identification of the presence of the autoantibody correlated with the development of some adverse event, specific adverse event actually. Specifically, hypophysitis and pneumonitis was correlated to the presence of autoantibody before administration of immune checkpoint inhibitors. So another study of patients also treated with Pembro, which is PD-1, up to 80% of patients who developed thyroiditis or hypothyroidism has anti-thyroid antibody, comparing to only 8% of patients has anti-thyroid antibody without developing the hypothyroidism. So this graph can just summarize the contributing factor for the incidence and occurrence of immune-related adverse event. As we said that increasing T-cell activity against healthy cells, also increase the level of pre-existing autoantibodies, and increase the level of inflammatory cytokines. In regard to risk factor of the occurrence and incidence of immune-related adverse event, actually it is poorly elucidated and it's not fully recognized, but however we have some contributing factors such as using combination of immune checkpoint inhibitors such as ipilimumab plus nivolumab, which is commonly used for several indications. So using combination therapy increase the risk of immune-related adverse event. Also, dosing of immune checkpoint inhibitor, the higher the dose correlated with higher incidence and high grade or higher severity of immune-related adverse event. And it was in the clinical trial, specifically with ipilimumab, when they're comparing the 3 milligram per kg dosing compared to 10 milligram per kg dosing. With incidence of severe adverse event grade 3 and upper grade, with 17% with the 3 milligram and 31% of incidence with the higher dose 10 milligram per kg. Also, the variances in microbial gut flora affecting the incidence of colitis and diarrhea in patients treated with ipilimumab. Also, the personal history of or the presence of autoimmune disease was correlated with the incidence of immune-related adverse event, and actually some recent evidence suggesting that higher risk of disease flare, it is a high risk of disease flare rather than a de novo immune-related adverse event, and usually those population or these patients excluded from a clinical trial of immune checkpoint inhibitors. Moving to the incidence and some epidemiologic data, CTLA-4 inhibitor generally have a higher rate of immune-related adverse event comparing to PD-1 and PD-L1, with an incidence of reaching with CTLA-4 90% of patients taking the CTLA-4 and up to 70% for patients treated with PD-1, PD-L1. And usually the timeline for occurrence of such adverse event ranging from 3 to 6 months of occurrence. And for CTL4, usually within 12 weeks. However, the timeline for PD-1, PD-L1 ranging from 1 to 6 months. This is some example of the most common immune-related adverse event. The highest was in the clinical trial skin reaction, dermatologic reaction, including or presented as skin rash and pruritus, and most commonly seen with CTLA-4. Also, we have gastrointestinal presented as diarrhea and colitis, most commonly also with CTLA-4 inhibitor, which is ipilimumab. And we have endocrine reaction, including hypothyroidism and hypophysitis with PD-1 and CTLA-4, and lastly, pulmonary presented as pneumonitis. Starting with the dermatologic reaction. Starting with dermatologic reaction, it is one of the most common adverse event seen about 45% with ipilimumab and up to 34% with PD-1 inhibitor. Skin reaction commonly occur within the first few weeks of treatment and commonly presented, as I said, with skin rash and pruritus. Vitiligo also has been reported up to 8% of the melanoma patient. However, the most important thing in the vitiligo that the occurrence and the presence of vitiligo after treatment with immune checkpoint in melanoma, specifically in melanoma patient, is positively associated with the clinical response and the clinical efficacy. Management usually of the rash and inflammatory dermatitis based on the grading within the low grade. First of all, that I would to mention that there is no clinical trial assessing or evaluating the treatment of immune-related adverse event. These recommendation based on clinical experience. So based on the grading, the low grade, grade 1 usual management with topical emollient and topical mild moderate corticosteroid. For grade 2, we may consider holding the immune checkpoint inhibitor, and we may also consider a systematic steroid, and also using a topical high potency steroid. For grade 3 and grade 4, we usually recommend to hold the immune checkpoint inhibitor and to consult dermatologist. Also starting IV methylbrid at a dose 1 to 2 milligram per kg, and to use combined with the topical steroid. For GI toxicity, it's usually presented as diarrhea and colitis. For diarrhea is the most commonly reported with ipilimumab compared with PD-1 inhibitor, and it is the more, colitis usually presented as 8 to 22%. Diarrhea is one of the most common grade 3 adverse event related to immune checkpoint inhibitors, and also is the most common of ER visit among patients treated with immune checkpoint inhibitor, to an incidence with more than 25%. This toxicity usually occur within almost 1.5 and 2 months. The management of diarrhea and colitis usually based on a grading. For grade 1, usually we may continue immune checkpoint inhibitor with close monitoring, and we could also hold the agent. We may consider loperamide and monitoring the hydration status. For grade 2, we may hold the immune checkpoint until reaching to low grade or less than 1. We have to consult gastroenterologist and initiating systemic steroid. For grade 3 and grade 4, usually as grade 2 plus, we may introduce treatment of methylbrid and infliximab in refractory patient. For hepatic toxicity, typically occur in about 5 to 10%. And patient using combination therapy will have more severe hepatotoxicity and high incidence of hepatotoxicity reaching up to 15%. And usually hepatitis tend to occur within 8 to 12 weeks after starting therapy. And usually hepatotoxicity presented as asymptomatic elevation of liver enzymes. So monitoring of hepatic or liver enzyme and bilirubin is very crucial before starting each cycle of immunotherapy. The management usually based on the severity of the elevation of the liver enzyme. Usually we, in grade 1, we may consider holding the agent with close monitoring and assessment of bilirubin. For grade 2 and above, we have to hold immune checkpoint. And for grade 4, we will permanently discontinue the immune checkpoint inhibitor. Treatment similar to the previous toxicity by systemic steroid and frequent monitoring. However, in hepatotoxicity, usually we are avoid using the infliximab. For endocrine toxicity, usually endocrine is presented as thyroid dysfunction, hypophysitis, and in some cases adrenal insufficiency. And they are typically appear later after starting therapy, and they are the last to reverse. Opposed to other immune-related adverse event, endocrine toxicity tend to be permanent and usually treated or require hormonal replacement. Monitoring of endocrine parameter is very crucial. Starting with thyroid toxicity, usually presented as hypothyroidism and more than the hyperthyroidism. Hypothyroidism occur more frequently with anti-PD-1 comparing to CTLA-4 inhibitors. Thyroid dysfunction usually occur fewer weeks after initiation of therapy within and a median of 1.5 months. This is the treatment of or management of thyroid toxicity. For low grade, we may continue immune checkpoint inhibitor with a close monitoring. For grade 2 and above, we may hold the immune checkpoint inhibitor and starting thyroid supplementation. And the treatment usually similar to regular hypothyroidism for symptomatic patient. For severe grade or grade 4 and above, usually we will hold the immune checkpoint inhibitor, but we may re-challenge the immune checkpoint inhibitor once the patient is stabilized.
5 minutes.
For hypophysitis, usually presented with, or more common with CTLA4, and tend to present within almost 2 months. And the treatment include correcting the endocrine abnormality with a steroid. For primary adrenal insufficiency, it is the most severe endocrine immune-related adverse event, presented almost of 1% in immune checkpoint inhibitor patient who receive immune checkpoint. The management mandate hospitalization and aggressive hydration with intravenous stress dose of steroid. For pulmonary toxicity, the incidence reaching up to 10%. In combined analysis of almost 900 patients treated with PD-1 and PD-L1 therapy, the pneumonitis developed in 5% of patients and the onset within 9 days. The incidence appear higher in patients receiving combined PD-1 with CTLA4 therapy than the monotherapy. However, pulmonary toxicity common with PD-1 or anti-PD-1 therapy. Also, it is unclear if the presence of pulmonary toxicity, which is pneumonitis, if it is correlated with the type of cancer. And in some studies, it's showing higher rate of pulmonary toxicity in patients with renal cancer and lung cancer. However, in other study, it was not, so we could not give a clear answer if it is correlated with the type of cancer or not. The most important thing here that patient presented with pulmonary toxicity, more than 50% of these patients will be presented with other adverse events, such as dermatologic reaction or colitis and thyroiditis. The management usually the same, start with holding the immune checkpoint inhibitor and also to consider starting steroid. In grade 2, we may consider starting empiric antibiotic. And for severe cases, we permanently discontinue immune checkpoint inhibitors with treatment of steroid. Also, with for refractory patient, we may introduce infliximab and broad-spectrum antibiotics. This is the timeline of common incidence or occurrence time of immune checkpoint. We can see in combination therapy on the right, the incidence or occurrence earlier in the time or in the duration of treatment. Other immune checkpoint inhibitor less common and rarely seen, such as musculoskeletal toxicity, renal toxicity, nervous system, and cardiovascular and hematologic. This is a real-world safety experience with immune checkpoint inhibitor in Saudi Arabia. Actually, it is one of our colleague, Dr. Nhait, in National Guards in Riyadh, did this study. They include 53 patients of immune checkpoint inhibitor receiver. They found that fatigue was the most common reported adverse event and commonly reported with nivolumab and atezolizumab, followed by nausea, arthralgia, then diarrhea, followed by hepatitis, and the last was a skin reaction. The adverse event that lead to discontinuation of treatment reported in 35% of our population. So we reach to the take-home message. As we said, immunotherapy is showing improvement in overall survival in cancer patients. However, they have inflammatory side effect or immune-related adverse event. The incidence reaching to 70 to 90% based on the drug itself and patient characteristic. Usually presented as dermatologic reaction followed by GI reaction. Monitoring is very, very crucial. And general management by holding the agent with introduction of steroid and infliximab for refractory patient. And thank you.
Thank you so much, Dr. Nezi, for this informative session. I know how the new innovations actually causes a lot of multi-organ toxicities and adverse events, and you enriched us actually with this lecture, and you have exposed us actually to the side effects that we never actually heard about. Thank you so much. Thank you. Actually, we have a little bit, change to the scientific program. So now we'll take the lecture of Dr. Samah. Dr. Samah Fathi, she's actually an associate professor of forensic medicine and clinical toxicology at the College of Medicine at Noura bint Abdurrahman University Hospital in Riyadh. Dr. Samah, today she will talk about the apoptic and cranial toxic effects of perchlorate in a human placental cells. Dr. Samah, please join me.
Bismillah, assalamu alaikum wa rahmatullah. First, I would like to thank Dr. Maha Mazroua for her invitation and successful. I wish her for more successful conferences in the future. And I will start now, inshallah, a research paper that is talk about the perchlorate. It is a part of chemical, environmental chemicals that have molecular toxic effects. This research paper is already done by Dr. Mona Ali, Sarah Khater, Amal Faid, and Dr. Dina Sabri, and it will be presented by me. We will talk about the background and the material methods, results, conclusion, recommendation, and reference to see how we conduct this research and how we already think about this research and this idea. Regarding the perchlorate, what is the perchlorate? It is a natural occurring substance that is induced by oxidizing of the chlorate salts. It can contaminate the drinking water, growing plants, and the sea creatures. If the human body exposed to this contaminated water or plants or sea creature, the body will absorb this chemical and the whole body organs will be exposed to this chemical and the fetus can be exposed in the pregnant female. After 12 hours, this chemical will be excreted from the body unchanged and can be excreted in the milk in the lactating woman. There is already a research papers discuss this, the toxicity of perchlorate on the thyroid and testicular tissue. They said it inhibits the function of the thyroid and inhibit the T3 and T4. Regarding the testicular toxicity, it already decreased the spermatogenesis. So we start to think about what about the placental tissue. So this is the main idea of our research. When we, there is a toxic effect of the perchlorate, so how can we prevent it? How can the perchlorate induce these toxic effects? As we said, the perchlorate is an oxidizing agent. So it is increase the oxidative stress in the body, increase the lipid peroxidation that can alter the gene expression and initiating the apoptosis. But this is the mechanism that is found in the researches. How to prevent the perchlorate toxic effects? In each country has occupational safety and health administration that announces the limit of exposure to this chemical. In the developed countries, it is within from 2 to 15 microgram per liter. So we start to think when we want to conduct this research, what is the concentration of the perchlorate will be used. So we stuck to these limits. We said that we will use 2 concentration. Lowest concentration will be 5 microgram per liter, and the highest concentration is 50. So the research idea now is how to detect the detect of the toxicity of the perchlorate in 2 concentration. The lowest one is 5 microgram, and the highest one is 15 microgram per liter in the placental tissues. The aim of the results is to detect the perchlorate toxicity on the human placental tissue in the both concentration, as I said, and to detect the possible mechanisms. We search for the reactive oxygen species production and the caspase expression and the apoptosis. Regarding the placental function, we see the placental cytochrome aromatase, which is a key for production of the androgen and the estrogen. Then lastly, we see the placental cytotoxic effects and the viability of the placental cells. The material we already took it in our research. First, we have an ethical approval and the informed consent from each pregnant woman to have and to collect the placental tissue. Then after delivery, we collect the placental tissue. We start to differentiate the human placental-derived human mesenchymal stem cells using the cluster of differentiation. Then we start to separate the placental cells into 3 groups. The first group is the control group. It is unexposed group. The second one is the group 1, which is exposed to the lowest concentration, 5 microgram per liter. And the last one is the third group, which is exposed to the highest concentration, 15 microgram per liter. We start, as we said, to detect the mechanism by detection of the reactive oxygen species production by ELISA technique, and the caspase assessment. We see it by the Western blot technique and the immunohistochemical technique. Then regarding the placental function and the placental cells viability, we detect the placental function by cytochrome microsomal cytochrome B19A that is assessed by the fluorometric technique, and the cell viability is detected by MTT reagent, which is detected by spectrochemical technique. We already do this research and start to collect the data and put it in the SPSS version of 21. Each parameter is measured 14, and the times and the mean and the standard deviation is already tooked. The data is for 3 groups were compared using the ANOVA test. Results first. Regarding the reactive oxygen species, we found that the reactive oxygen species is already induced by the higher concentration and the duration. The first one in blue is day 1, in red is day 2, and the third one is green and is day 3. We found there is an 1 to 1/2 to 3-fold increase in the reactive oxygen species production. Reactive oxygen species is already needed for normal human placental cell growth and development, but exaggeration can lead to death, or starting of the apoptosis and death of the cells. Regarding the caspase 3 expression, we also found that it is increased with the duration and the concentration of the perchlorate. The higher the concentration and the higher the duration can lead to more caspase 3 expression. Caspase 3, it is the end product of the pathways of the apoptosis in the intrinsic and the extrinsic. Caspase 3 is needed, as we said, for the normal growth, but its higher expression can lead to unaffordable pregnancy outcome. Regarding the function of the placenta, cytochrome 19A activity, we found that it is reduced with increasing the concentration and increasing the duration. Regarding the cellular viability, we saw we already found that the cellular viability is significantly decreased in the third group, which is higher concentration, and the highest significantly is found in the day 3. But interestingly, we found that in 5 micrograms, the lowest, the second group, the cellular viability is not affected. So we have a question mark about this. To prove these results, we start to see the CASP3 in the whole groups. We found that in the CASP3, expression is already increased in the group 3 and with higher duration. To be confident of our result, we start to see the apoptotic bodies. We found that it is already not found in the group 2, but it is presented in the group 3 with higher duration. Conclusion, enilperchlorate has toxic effect on the placental cells and has endocrinal toxic effect that is already needed to normal placental growth and fetal growth. The highest concentration of the rate, 15 microgram per liter, is significantly affect the placental cell viability. Recommendation, we recommended that in the permissible exposure level of perchlorate should be revisited, especially for the sensitive individuals like pregnant women or lactating women. More researches are needed to detect the response dose toxicity effect and continuous monitoring of the human exposure level. These are the references which is already used in our research. Thank you.
Thank you so much, Dr. Samah. You actually indulged us in an experience that's never been actually exposed to. So, you know, having a very basic science, let's say, results out of, you know, your scientific publication, this is something that we are really admired. And on behalf of the audience, we just want to thank you so much for your contribution, actually. Thank you so much. Should we move for Dr. Suleiman? Okay. Actually, we'll close the loop actually with the, you know, the effect of anti-cancer toxicities. So Dr. Suleiman Zuberi, he's actually the clinical pharmacist at Johns Hopkins Aramco Healthcare Services. Today, he will actually tell us how to manage the chemotherapeutic-related toxicities. And this is actually complements Dr. Al-Anizi's presentation. So I believe now we are in sync. Yeah, now, all right. Please, warm welcome, Dr. Suleiman.
Thank you. Okay, thanks for waiting this long. I know it's the last maybe live session in this part or on this day, and I'm an oncology clinical pharmacist. And considering this is a toxicology conference, we tried to bridge things together. So we're going to talk about chemotherapy-related toxicities. And considering this the last session, we'll try to make it a little bit light and fun. So this shot was actually taken from a TV show on Netflix. Who here has a Netflix account? A lot of us. And who shares a Netflix account with about 20 family members and friends? Oh, no, not me, actually, okay. But sometimes if you look at movies or TV shows, you basically can see the diseases that you see in the hospital or clinics that you work in. I remember when I had my psychology rotation when I was an intern, which was more than 2 decades ago. So at that time, my preceptor asked me to see one movie, which was Beautiful Mind. And it was the first day in the rotation he asked us to go and watch this movie. And after that, I understood what schizophrenia was. And at that time, psychology or psychiatry became my second preferred subject, because if there are any interns here, I would recommend that maybe you pursue psychiatry, because have you ever seen anybody with psychiatric or mental illness that had a surgery? More likely, no. It's mainly medication. And I don't see a lot of psychiatric clinical pharmacists in Saudi Arabia, and I think this is a good specialty to go for. Going back to oncology, this TV show had actually a patient who had breast cancer. Her name was Laura Oliver. Let's suppose that this was your patient, or this was the patient in your clinic or hospital, and Laura came with a complaint of lower back pain. And unfortunately, a lot of patients, based from my experience with friends or family member who call me and ask me about their loved ones, they come at a late stage, because we encourage everybody to do screening. You know, at a certain age you have to do colonoscopy, at a certain age you have to do a prostate exam, pap smear, pelvic exam, and so on. So this patient obviously came in a late stage, and then radiological exams has revealed that she has a metastatic breast cancer to distal organs, such as bone, lung, etc. So there is no correct or wrong answer in oncology. So if I ask you at this stage, what would you recommend for this patient with this late stage cancer? Should we not give her chemotherapy because it will be ineffective? Or we should not give her because it is toxic? Or we should give the patient a chemotherapy that is a palliative that would help her with improving quality of life and moving and walking, etc. Or finally, she should receive a high intensity chemotherapy with intent of cure. Can anybody guess number 1? 2? 1? Okay. 2? 3? Okay, I see more 3. 4? Okay, so there is no correct or wrong answer, but if you ask me myself, I would go with a palliative chemotherapy, because she's in a late stage, and a lot of people would think that, okay, we shouldn't give the patient chemotherapy at all. A friend of mine, his brother just recently was diagnosed with pancreatic cancer, and it was metastasized. And he was worried about chemotherapy because of hemodialysis. But eventually they are giving him a chemotherapy that is not toxic. So the correct answer, in my opinion, which could be correct or wrong, is 3. Do I press here or? Okay. Does this work? How do I go next? You? Okay, next, please. Yeah, next slide. Okay. All right. Go back. Back when click. Okay. So now the controversy that comes, whether we should treat or not treat, because if you're giving chemotherapy, you will be hitting also the normal cells as well. For example, if you look at certain chemotherapies, with them we give rescue therapies such as folinic acid or vitamin B12 and so on, because this is mainly related to antimetabolites that inhibit the growth of the cells, and they might prevent the formation of folinic acid and vitamin B12, etc. And that's why we give them as a supplement. For example, have you heard about the colon cancer treatments? They're called Folfox, Folfiri, and stuff. Fol, it stands for folinic acid. But sometimes, you remember our patient, we said we will give her chemotherapy. We're not gonna prevent her from the chemotherapy because it's toxic. But in some cases, the risk outweighs the benefit, especially if the patient does not have symptoms in like lymphoid cancers. Next, please. Can you please watch me when I'm talking? This one? Where should I press? Okay, we got it, thanks. Okay, so if you look at the lymphoid part here, and the second lineage, the other side, you will see that in blood cancers, the lymphoid lineage affects only lymphocytes, while the myeloid lineage affects white blood cells, a big portion of white blood cells, RBCs, and platelets. So if patient has a lymphoma that's not symptomatic and indolent and benign, the risk of giving chemotherapy is worse than what we are getting. So in this case, we would watch and wait. But for other tumors, like our patients had lower back pain, which means that she had maybe spinal cord compression. And if we give her chemotherapy, it might help her with her disease. So in this presentation, we will touch bases on tumor lysis syndrome, infusion-related reactions, extravasation, febrile neutropenia, hypercalcemia, and some other toxicities as well. So for tumor lysis syndrome, from the name, it's a lysis of the tumor. So when the tumor breaks down, the content of the cells will come out. For electrolytes, mainly, we're talking about potassium and phosphorus. Potassium, if you look at potassium and you look at the normal value, does anybody know the normal value of potassium in the serum? It's 3.5 to 5.3, exactly. And if you look at the phosphorus, it's about 2 to 4 in that range. But if you look at sodium, it's 135 to 153. Chloride is around 100 because sodium and chloride are extracellular electrolytes, while phosphorus and potassium are intracellular. So when the cell breaks down, we'll have high potassium, high phosphorus. And this is similar to which disease? It's similar to renal failure. Renal failure patients have hyperkalemia, hyperphosphatemia, etc. So if the patient has already impaired kidney function, we will have a challenge with tumor lysis syndrome. In addition to the electrolytes, breakdown of the cell contains DNA. And the DNA eventually, purine, pyrimidines, break down to xanthine. And here where the tumor lysis syndrome medication work, allopurinol inhibits xanthine oxidase that will lead to formation of uric acid, and rasburicase, Elitec, will increase the excretion or conversion of uric acid to the inactive metabolite. If you have rasburicase or heard about rasburicase, it can be used also as prophylaxis for tumor lysis syndrome. So if you look at this criteria I got it from one of the hospitals that I worked for. And if you want to use it for prophylaxis, the patient must have high WBCs and high LDH. Why is that? Because that means the patient has a bulky disease. So if you want to, for example, demolish a large building, you will get big debris. If you demolish smaller building, the debris would be less. So if the tumor is larger, you expect if you give chemotherapy, the tumor lysis syndrome would be worse. And one thing about rasburicase, if you look at the package insert, it says the dose is between 0.1 to 0.2 milligram per kilogram daily for a few days. But in fact, it's very effective that one dose is enough. So a lot of hospitals should adapt a protocol that's called for one dose only, 7.5 in this protocol. Other hospitals use 4 or 6 milligram. Also, the medication is expensive. I think now it's generic. If you look at the Saudi FDA drug list, 1.5 milligram is 1,000 riyal. It used to be much more than this before. And if you're giving it for a larger patient for a few days as weight-based medication, you will be wasting a lot of resources because this medication is very effective. I have never seen a patient who used it and their uric acid was not normalized. They even collect the blood sample for uric acid and put it in ice bath. They put it in a Ziploc bag with ice in it. So the medication does not work in the sample while they transfer the sample to the lab. With that being said, rasburicase also is contraindicated in G6PD deficiency patients. Moving to the second toxicity, which Dr. Al-Nazi touched in his previous talk, which is infusion-related reaction. I listed here the monoclonal antibodies, or some of them. Monoclonal antibodies, they end with the letter MAP, the suffix MAP, and that means monoclonal antibody. And the letter before this, the infix before this, tells you the source. For example, the first one is alituzumab. ZU is before the MAP. That means it's humanized. O in the second agent, which means it's coming from mouse. XI means it's chimeric. If it's U, it's fully human. And most of us have seen rituximab in practice. And rituximab is known to cause allergic reactions. And now rituximab became sub-Q. I don't know if you're a hospital or if you work in a hospital, if you got the sub-Q, but I haven't noticed any, I'm not marketing for this, but I haven't noticed any reaction with the sub-Q rituximab so far. And usually we give pre-medication for these agents. We give antihistamine, anti-H1, H2, such as diphenhydramine, H2, famotidine, and sometimes you give steroids. And we try to give either methylbrad, as Dr. Al-Nazi mentioned, or we can give hydrocortisone. But in case of reaction and you want a very quick action, you would use hydrocortisone because it's faster than methylbrad. Also, cyanogenol can be used as a pre-medication because one of the signs of toxicity or infusion reaction is fever. So these are the grades of infusion reaction, which are similar to the allergy grades. And in grade 1 and 2, you can reduce the infusion and re-challenge. But in other grades, maybe you want to stop the medication and use another agent. And, but sometimes some medications are very essential that you can re-challenge. If you re-challenge the patient, you will be able to give the medication again. For example, patients who have sulfa-allergy, especially if they will get bone marrow transplant, we want to give them Bactrim for prophylaxis of pneumocystic xerophagy, PCB. And if the patient has sulfa-allergy, you have to use 2 agents to prevent PCB, such as Mebron, Dapsone, and you have to use a second agent for encapsulated bacteria, such as penicillin V. So you have to use 3 agents. Sometimes you would use trimethoprim by itself without sulfa. If you give trimethoprim, it's similar to chemotherapy. It works on the folic acid production. So you have to give leucovorin with it. You will end up giving 4 medication instead of giving just Bactrim alone. So that's why sometimes you want to re-challenge the patient with sulfa-allergy and some sort of allergies, like for chemotherapies that are active in certain diseases, such as anthracyclines and lymphoma, etc. Next, we talk about extravasation. Extravasation is the infusion of intravenous medication outside the vein, in the tissue surrounding the vein. And we can divide medication in terms of reaction to extravasation into vesicants and irritants. Vesicant agents such as anthracyclines, like doxorubicin, daunorubicin, epirubicin, etc. Vinca alkaloids, such as vincristine, vinblastine, and taxanes, such as paclitaxel, which is very commonly used in breast cancer, and docetaxel. And each agent has its own antidote, if any. Sometimes you don't have to give anything, especially if the medication is a monoclonal antibody, because if it's fully human, you're given a human product into a human body, so there will be not much extravasation or reaction. But for vesicant agents, we try to give them as IV push if they will be given peripherally. So IV medication are given either as a peripheral line or they're given as a central line. So central line would be a catheter that will be placed in the patient, and they would go home with it and come back, especially if they're getting chemotherapy like weekly or every 3 weeks, etc. Peripheral medication would be given in a line, like in the arm or so on. But the issue with peripheral line, you run for the risk of extravasation. So if it is anthracycline, we try to give it as a syringe. So the nurse would be sitting there and giving the medication to the patient. So that way, unlike if you're giving piggy bag, you hang the piggy bag and the nurse would go. Sometimes the patient would be sitting on their phone or sleeping, and there would be a risk for extravasation. There is an exception actually for giving IV push. Vincristine and vincalcaloids, we don't give them as IV push, even though they cause extravasation, because vincristine is very active in lymphoma and lymphocytic leukemia. And a lot of these protocols, in these protocols, we give them typically in the same day with intrathecal chemotherapy. The lymphocytes, they can penetrate the blood-brain barriers, and they might cause CNS disease. And therefore, they give intrathecal or CNS prophylaxis. So they don't want the tumor to go to the brain. The intrathecal chemotherapy is given in small volume, between 3 to 8 mLs. And most of the time, in the protocols, it's given in the same day as vincristine. Vincristine is 2 milligrams, so they put it in a 3 ml syringe. And on the same day, you will be getting the intrathecal in 3 ml to 5 or to 10 ml syringe. So if you give vincristine as intrathecal, does anybody know what happens? More likely death. And it had happened in some of the biggest hospitals in the world. So, but at the same time, vincristine causes extravasation. So which one worth caring for? The error of giving vincristine as intrathecally. So now we give vincristine as a picky bag. But to avoid extravasation, we don't give it through the pump. We allow the gravity to pull the medication. So we hang it without infusion pump. Or we can picky bag it with an IV fluid. So that way it doesn't push against the vein or cause extravasation. Okay, so next we discuss neutropenic fever. So neutropenic fever or febrile neutropenia word has two components, febrile, fever, or neutropenia. Okay, so based on the patient condition, we can give empiric therapy. Typically, if the patient is in the hospital, we try to give them empirically after taking 2 blood samples from 2 different sites. We try to give them something with a broad coverage. Can anybody give me an example? Okay, so cefepime, something that covers Pseudomonas, like cefepime, ceftazidime. But cefepime and ceftazidime, they don't cover anaerobes. So if the patient has GI symptoms, we have to give something with them. We have to give 2 antibiotics. But if we give carbapenem, like meropenem or imipenem, or piperacillin tazobactam, they cover anaerobes, so we don't have to give a second agent if they have GI symptoms. If the patient has like line redness or mucositis, we expect that the skin barrier is broken, and that might allow for gram-positive infection, and we give vancomycin in that case. Cancer hypercalcemia, it's not mainly related to, it's not due to chemotherapy, it's related to the cancer itself. And when we talk about oncology as a profession as well, since I brought this point, one thing about the oncology is that we have 2 concerns. We have symptoms that are coming from the cancer, and we have symptoms that are coming from the chemotherapy. That's why there is a big role for a pharmacist in this specialty as well. So for hypercalcemia, we give hydration first. Once the patient is hydrated, we give bisphosphonates such as hyaluronic acid. How do we know that the patient is hydrated? When they urinate. When they urinate, we know that they're hydrated. We can go to the next step. Then in the next step, we said bisphosphonate, the hyaluronic acid. If you look at the package insert, it tells you that you have to adjust for kidney function. But that's applying to the like monthly or every 6-month dose that you give, for example, for bone metastasis or osteoporosis, but does not apply to emergency hypercalcemia, because most of the time this patient would have some sort of renal impairment. We can give the medication in a larger volume instead of 50 or 100 ml. We can put it in 250 cc bag and run it over 4 hours instead of 15 minutes. Instead of having to give like a more expensive agents such as denosumab, or have the patient have hypercalcemia for a few days with symptoms and so on. All right, I'll go back. Okay, so I'll end my slide with this. This is maybe if you have students or interns, you can use this slide to explain the toxicity of chemotherapy. And for example, you look at the V in the LIMS, that means vinca alkaloids or paclitaxel and so on. You can look this up online. It's called, you can Google Chemoman, you will get this case. And it will tell you how to deal with it. For example, cyclophosphamide, hemorrhagic cystitis, you give Mesna and so on. With that, I will end the presentation, and I think the questions will be at the end of the session. Thank you.
Thank you so much, Dr. Zubairi, for the informative presentation. Actually, we enjoyed every single information that's been reflected on your slides. Thank you so much. Now we have actually, last but not least, the last lecture of the conference, and today is actually a recorded one, which will be delivered by Dr. Lamis Mohammed. Dr. Lamis Mohammed, she is working as an associate professor at College of Medicine at Cairo University, Egypt. She will tell us about the endocrine disrupting chemicals and the health impacts and the preventive strategies. Audiovisual team. All right.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everyone. I am Dr. Lamis Nader, Assistant Professor of Forensic Medicine and Clinical Toxicology at Cairo University. It's my pleasure today to participate in the Conference of Knowledge, Skills and Abilities in Pharmacy and Toxicology in Saudi Arabia. And I would like to thank the organizers of this conference for inviting me for a talk today. My talk will be about the endocrine disruption chemicals, which is one of the most recent interesting topics, which is associated with a lot of arguments and debates regarding the toxic effects of those compounds on the human health, as well as the safe amount that should be present in the daily consumed products so that to avoid the toxicity of such chemicals. My objectives will be defining the endocrine disruption chemicals, going through the groups, sources, and routes of exposure of the endocrine disruption chemicals, explaining the mechanism of action of endocrine disruption chemicals, discuss the effects of endocrine disruption chemicals on the different stages throughout the human life, as well as on different body systems, emphasize how the compound bisphenol A is an endocrine disruptor, highlight the important precautionary steps to be taken to minimize the exposure to the endocrine disruption chemicals. I hope that the topic will be interesting and we will be benefiting from the information gathered and collected in such a topic, inshallah. Let me start first by the definition of endocrine disruption chemicals, because actually, as has been discussed recently, in 2021, there is no universal definition for the endocrine disruption chemicals, and various definitions have been used by different agencies across the world. But I have found two important essential definitions which are commonly used worldwide. The first one is according to the US Environmental Protection Agency, where it has identified the endocrine disruption chemical as an exogenous compound which may interfere with the synthesis, secretion, transport, metabolism, receptor binding, or elimination of endogenous hormones. And so it has the ability to alter the endocrine and the hemostatic systems. Also, one of the most widely accepted definition is the one which is stipulated by the WHO and the International Program on Chemical Safety, which states that an endocrine disruption chemical is an exogenous substance or a mixture of substances that alters the function of the endocrine system and consequently can cause adverse health effects in an intact organism or its progeny or the subpopulation. What about the groups of endocrine disruption chemicals? Endocrine disruption chemicals are found in many everyday products, famously included in some plastic bottles and containers, liners of metal food cans, detergents, flame retardants, food, toys, cosmetics, and pesticides. And according to their origin, we can classify the endocrine disruption chemicals into four main groups. The industrial group, which include the dioxins and the polychlorinated biphenyls and the alkylyl phenols. The agricultural group, which include pesticides, insecticides, herbicides, fungicides, as well as the phytoestrogens. We have the residential group, which include the phthalate, the polychromated biphenyls, and the bisphenol A. And then we have pharmaceutical group, which include the parabens. But actually, even the heavy metals such as cadmium, lead, mercury, and arsenic could be included in the long list of the endocrine disruption chemicals. As we can see here, this is the phthalate, which is one of the famous compounds that are present in the daily products, and I think it is clear here that it may be incorporated in most of the daily consumed products. The children toys, the baby objects that the baby can use, the paints, the automobile objects, the building objects. There are a lot of objects where the phthalate could be included in and consumed by human and can cause their toxic effects. These are the major sources and the effects of the endocrine disruption chemicals on the different body systems. Most of those effects have been reported and evidenced by the epidemiological studies, and some of them has been proved by in vitro and animal studies. The most famous sources of the endocrine disruption chemicals are the plasticizers, which include the phthalate and the bisphenol A, as well as the polyfluoroalkyl compounds. The second most famous group is the pesticide, which could include the organochlorine, which is included also in the plasticizers. We have the flame retardants, and the most famous compound is the brominated flame retardant. We have the environmental pollutants, which are commonly present in food, like the organotenes and the dioxins. And then we have the surfactants, which is mainly including the alkylyl phenols. Actually, the phthalate compounds have been associated with obesity and insulin resistance. The bisphenol A, which is one of the famous compounds encountered in the daily consumable products, is associated with diabetes and liver abnormalities. The polyfluoroalkyl compounds have been proved to be associated with increase in the cholesterol levels. The brominated flame retardant has been proved to be involving the pathogenesis of the metabolic syndrome as well as diabetes. Organotenes have been proved to play a very important role in adipogenesis induction, as well as dioxins also, which can also play an important role in the development of the metabolic syndrome and diabetes. And then the alkylyl phenols have been proved to play a very important role in resistin expression by upregulation, which has been proved by in vitro as well as animal studies. Resistin is a hormone which is responsible for glucose metabolism, and they play a very important role in insulin behavior inside the body. What about the routes of exposure? Actually, most of the endocrine disruption chemicals have their own ways and have the different routes to contaminate the human body. But in general, inhalation, food intake, contamination of water, and direct contact represent the most common exposure pathways. We can see here also the common pathways where we could be exposed to those toxic materials. So we can see the pregnant lady can transmit those toxic materials to the fetus in utero, and this could occur through the placenta or after delivery through the breastfeeding, as well as through the lady or the human could be contaminated by the dermal exposure, the inhalation, and the oral ingestion. And according to these pathways, the endocrine disruption chemicals could easily enter the food chain and accumulate in it. And being highly lipophilic, they do have the ability to accumulate in the adipose tissue, and that's why they have generally long half-life. These two features enable and explain the endocrine disruption chemicals to accumulate for years in the adipose tissue of any animals and cause co-contamination. Humans, as well as other big mammals and top predators, which are at the top of the food chain, can store larger doses of endocrine disruption chemicals according to the processes of bioaccumulation and bioamplification. And actually, these two processes could generate what is known as a cocktail of effects due to the cumulative effect of those co-contaminants with unknown sequences. What about the mechanism of action? How do endocrine disruption chemicals exhibit their actions inside the body? They do that by the endocrine activity or by causing deterioration or pathogenic endocrine-mediated activity. Also, they can cause an effect relationship between the substance and the endocrine activity in exposed subjects. Furthermore, the European Food Safety Authority has suggested that most of the endocrine disruption chemicals are artificial substances that can interfere with the endocrine system, binding hormonal receptors and or regulating the genome expression. Actually, the epigenetic changes, whether the DNA methylation or the histone modification or the non-coding RNAs, have been proved to play an important role in the mechanism related to the endocrine disruption. And during the lecture, you will hear the epigenetic mechanism too many times, which emphasize the ability of the endocrine disruption chemicals to cause changes and to harm the human health through doing this epigenetic changes and affecting the gene expression. They could also mimic the hormonal receptors and bind to them, causing triggering of the action into the cells, as well as they could block the action of hormone and stop the signaling pathway where the action and response will not occur and the function will not be initiated. But we have to admit that the person's genetic predisposition to specific conditions, as well as the additional environmental risk factor that the person could be exposed to, can modify how a person could be affected by the endocrine disruption chemicals and how the body could react to those endocrine disruption chemicals. Actually, it has been proved that the endocrine disruption chemicals can influence the whole stages of the life cycle of the human being, starting from the preconception up to the aging process by affecting the process of developmental programming. So they do influence the fertilization process, the gestational process, then after delivery, the lactation, the period of infancy, childhood, puberty, adulthood, the pregnancy, passing those kind of harmful effects, the future generations, and also the old aged persons could get affected. As we can see here, the endocrine disruption chemicals have their effect on the mother and fetus, and then they can cause a lot of developmental abnormalities in the fetus, like small for gestational age, intrauterine growth restriction, disruption of the endocrine programming and metabolism, as well as in the period of childhood, they can cause obesity, endocrine disruption, thyroid dysfunction, pubertal changes, and during the period of adulthood, they do have an effect on fertility, obesity, metabolism, thyroid function, and it has been proved recently that they play a very important role in carcinogenesis. So as we can see, they do affect each and every stage in the human life. What about the effects on metabolism? Actually, it has been proved that the most prominent health outcome of human exposure to endocrine disruption chemical is affection of the metabolic system and the causing of the metabolic disorders, where prenatal exposure to low concentration of endocrine disruption chemicals has an impact on the cardiometabolic risk factors in the preschool children. Also, recently, endocrine disruption chemical has been classified as an environmental obesogene with metabolic disrupting effects on lipid metabolism as well as the pancreatic B cell functions. The mechanisms through which those obesogenes can contribute to the etiology of obesity is the direct promotion of the process of adipogenesis by increasing the number and the size of adipocytes, the promotion of the signal of adipose cell lines to the determinant of other cell lines, greater differentiation of the pre-adipose tissue toward the adipose tissue through activation of the proliferator activated receptor gamma. As well as they can promote the greater deposition of fat and the potential epigenetic mechanism that favor the activation of transcription factor of the adipogenic genes. I think this is the second time that I am mentioning the epigenetic mechanisms, which have been proved to play a very important role in the pathogenesis of the effects caused by the endocrine disruption chemicals on the human health. Those obesogenes can predispose some people to weight gain in spite that they are following a low caloric diet and the increase in their physical activity. For example, a very famous estrogenic chemical, which is diethylstilbestrol, has proved to play a very important role in the adiposity regulation, as well as the central and the peripheral energy bands. Obesogenes also can increase the risk for type 2 diabetes and lead to the dangerous combination of diabetes and obesity. Certain endocrine disruption chemicals may directly cause insulin resistance and affect the insulin production and secretion without any significant affection in the weight. The endocrine disruption chemicals can also disrupt the body glucose hemostasis by affecting post-insulin and the glucagon secretory cells. What about the endocrine effects? So the endocrine system is considered to be one of the most sensitive communication networks of the human body, which influences all aspects of human health and well-being, including the reproductive potential, the cognitive function, thyroid and metabolism, digestion, and hormonal balance. The environmental contaminators alter the endocrine physiology and produce endocrine disruption without acting as classic toxicants. Every endocrine axis could be a target for each endocrine disruption chemical compound. Their action is not only limited to a single axis or organ, but it is now clear that they can affect the hypothalamus pituitary gland thyroid axis, as well as the hypothalamus pituitary gland gonads, as well as the hypothalamus pituitary gland adrenal, which remain to be the main targets of the endocrine disruption chemicals. Recently, there was an evidence that has showed that the endocrine disruption chemicals can cause disturbances in the energy metabolic hemostasis, which alter the adipose tissue, increasing in the number and size of the adipose cells, resulting in impairing of the endocrine regulation of the adipose tissue and the adipocytokine production, reducing the basal metabolic rate and change in the regulation of the appetite and satiety. And this happens especially if the exposure occurs during the early periods of development. Endocrine disruption chemical exposure during pregnancy can have a negative impact on the developing fetus. It can cause disturbances in the thyroid hormone level, which play a critical role in the proper development of the brain. So the endocrine disruption chemicals can cause a reduction in the maternal thyroid hormones, which could influence the fetal brain development and increase the risk of behavioral abnormalities and learning disabilities in an unborn baby. Also, the fetal exposure to endocrine disruption chemicals can be a contributory factor to the development of language disorders, dyslexia, developmental delays, and attention deficit disorders in the children. It's clear here that it does influence the endocrine disruption chemical does has its hormonal effects in the brain, and it can disrupt the neuroendocrine processes at multiple axes. The thyroid hormones, which are very essential for normal brain development, as I have just mentioned, and play an important role in the regulation of metabolism, could be affected by exposure to endocrine disruption chemicals at different levels, including the thyroid hormone synthesis by various toxic compounds, which could affect the synthesis, release, transport, and the metabolism of the thyroid hormones, causing a lot of disorders and disruption, either by antagonizing the thyroid receptors, which can affect the thyroid-mediated transcriptional activities, or by having a direct action on the gene expression at the thyroid and pituitary levels. Again, the epigenetic changes which play an important role in the mechanism of the pathogenesis or like the pathology that could be caused by the endocrine disruption chemicals. A higher late pregnancy maternal bisphenol A exposure was associated with higher thyroid stimulating hormone levels in female newborns and higher free thyroxine levels during the childhood in males. In the newly born, exposure to multiple phthalate metabolites during pregnancy, the levels of the cord serum TSH and the FT4 were found to be significantly negatively associated with the phthalate levels in the cord serum. What about the effects on puberty? Puberty is considered to be one of the main temporal windows of the susceptibility for the influence of the endocrine disruption chemicals. They may act either as a single chemical agent or a chemical mixture affecting the pubertal influencers, accelerating or delaying the process of maturation of the secondary sexual characters, and they do have an influence on the timing as well as the progression of puberty. Moreover, recent studies have started to point out how the exposure to the endocrine disruption chemicals during the period of puberty may predispose to breast cancer later in life. In fact, the estrogen mimicking endocrine disruptors may influence the development of the breast tissue during the period of puberty in two ways, either by working on the proliferation of the breast stromal cells or by the epigenetic mechanism. As I told you, the epigenetic mechanisms are encountered in all of the mechanisms by which the endocrine disruption chemicals influence the different body systems. Urinary concentrations of bisphenol A were significantly higher in girls with premature TILAR compared to the healthy ones, and weak positive point correlation with the uterus volume, estradiol, and the luteinizing hormone were found in girls with premature TILAR. The association between the age of menarche and urinary bisphenol A was analyzed, and the association between bisphenol A exposure and delayed menarche was strongly suggested. Girls with intermediate and high levels of bisphenol A compared to those with undetectable levels were more likely to have delayed menarche. And there are some conflicting results which do not allow to clearly define the role of bisphenol A in the alterations of the pubertal development timings. The most common system that has proved to be affected by the endocrine disruption chemical is the reproductive system. So research has shown that the endocrine disruption chemicals can affect the female reproductive development, the fertility capability, and also the onset of menopause. Jacobson and his colleagues find a significant association between the serum concentration of phthalate metabolites in pregnant women and the occurrence of postpartum depression syndrome. Also, Anding and colleagues find an association between the exposure to bare fluoroalkyl substances, which are widely spread endocrine disruption chemicals, and the process of early menopause. These are the impacts of the endocrine disruption chemical on the female reproduction, where we can see that different substances could cause a different clinical effects, where famously the bisphenol A can cause the polycystic ovarian syndrome, as well as the other compounds could play an important role in the premature ovarian failure, aneuploidy, granulosa, stereogenesis, affection of the reproductive tract development causing certain anomalies, as well as endometriosis and recently breast cancer. Their effect on the male sexual organs is also severe, and they can affect the sperm quality and motility, where they affect the sperm count, the proportion of normal sperm, the sperm volume. They can influence the fertility either by an anti-androgenic effect or an estrogenic effect. They can cause benign testicular tumors. They can influence the process of testicular genesis, causing testicular dysgenesis syndrome, causing a lot of disorders and disruption in the development of the male reproductive system, which are famously the hypospadias and the cryptorchidism. Also, they lower the production of testosterone and other environmental factors, which are necessary for the normal testicular descent in the scrotum and the normal benign function. The maternal serum bisphenol A concentration has been estimated at the 10th to the 17 weeks of gestation and was found to be positively associated with congenital or postnatal acquired cryptorchidism. Clinically, it is very, very important to evaluate what is known as AGD, or anogenital distance, which is a very sensitive index of prenatal androgens action influenced by exposure to chemicals with anti-androgenic activity during the critical development of the fetal testes. This is like a diagram which can indicate or summarize the different abnormalities that could be caused by the endocrine disruption chemicals on the male sex organs. As I have mentioned earlier, it has been proven that endocrine disruption chemical could participate in the increased incidence of cancer all over the recent years. And although some of the increase in the cases of cancer was due to the improvement in the ability to detect cancer by the different technologies, but still this cannot fully.
Thanks, Dr. Lamis, actually, for this informative presentation. Actually, we need to stop her because, she's not with us here. Because we just want to get most out of the time and to receive more, let's say, questions from the audience here. So may I ask the esteemed speakers actually to join me in the stage. Now we will open the floor for discussion. If you have any questions, comments, or any concerns, our esteemed speakers are here actually to respond to yours.
Yes, my question goes to Dr. Zuberi. So I noticed that there is some medication that you highlighted in the table that were monoclonal antibody that can cause infusion-related infusion-related.
We can't hear you actually. Can you use this mic?
Okay, my question goes to Dr. Zuberi. I noticed there were some of the monoclonal antibody that were in the table that can cause infusion-related reaction. So my question is there any, is the degree of the severity difference in if this medication is humanized or chimeric, or were no difference?
Okay, so your question is based on the source of the monoclonal antibody. Is there a difference in reaction or not?
The degree of the severity.
The severity of the reaction or not? Basically, to my knowledge, sometimes, like if you look at the prefix or the infix U before the mab, it means fully human.
Yeah.
Some of the monoclonal antibodies, they are fully human, but they still cause reaction. So the source of the severity and the information of how we deal with the reaction is agent specific. And I don't think there is a general statement that we can say, okay, if this is chimeric, it has more reaction, or this is from mouse, it has more reaction than the human source. But yeah, this is a good question. But in general, the way we handle reaction for most of the chemotherapeutic agents is similar. So it would be like if you have a protocol or you have, for example, electronic health record, chemotherapy, they come in a plan and in a certain set or the sets, and there will be a section for reaction medications. And the nurse would be able to give these even without calling or something, because these typically are emergencies. So it will contain a diphenhydramine, antihistamine, anti-H1, anti-H2, famotidine, and a corticosteroid. And as I mentioned before, the corticosteroid that is preferred in case of emergencies is hydrocortisone, because it is short-acting, fast-acting. You cannot give dexamethasone, it will take a long time to work. And we can add also Tylenol, in addition to IV fluid. Yeah. Does that answer your question?
Yes, thank you.
Okay, thanks.
Well said, Dr. Zuberi. Do you have any other questions? All right, I have a question for you, Dr. Anizi, regarding the RAEs, which is the immune-related adverse events. So there should be actually risk evaluation mitigation strategies, which is actually accompanying, all of these medications. So I just want to know, at least for your practice, do you practice actually implementing these REMS on the, seriously in the hospital?
Thank you for this question. Actually, it's a great question and very important for monitoring the safety of such a new medication. Usually, up to my experience, we are registering those patients with the teratogenic medication. So these medications, such as immune checkpoint, actually I didn't cross hospital through my training or my working, registering in such a program such as REMS for this medication, usually for teratogenic.
Yeah, for sure the teratogenic medications, definitely it comes with REMS. However, for example, if we have high-risk medications that being used in the practice, there is some risk mitigation, let's say, activities. For example, the Dear Doctor letter, or if we have, let's say, patient guide, or any of these activities actually valued a lot in this situation, because some clinicians, some patients, they are not aware about certain high risk, let's say, adverse events. And by having REMS, this definitely will make an impact. The other question actually regarding the how serious are the immune-related adverse events at your practice? Do you report a lot of them? And are they really serious, or mild side effects, or 50-50?
Actually, in our population in the kingdom, as I showed in the one of the studies, it was done in one center, single center experience. The reaction usually in our population is more severe and different than, little bit different, let's say little different than the reported data in clinical trials. So our population is not tolerating as the patient in the clinical trials. So usually we have more reports than the one in the clinical trials, and we usually receive a lot of reports, specifically for immune checkpoint inhibitor. I think we may reach to 90 to 95 of our population we noticing immune reaction with our population. So in the literature, 70 to 90, and in our population reaching to more than 90.
Yeah, I can tell from the slide that you showed or demonstrated from I believe, Dr. Nhat. Yeah, he actually tried to quantify the adverse events that been reported with a couple of products at maybe National Guard. And I believe there is some sort of maybe genetic polymorphism, it's related to, multiplying the, or behind the increased rate of adverse events. So this is something that, we are putting now a hypothesis, and this hypothesis needs to be tested by if we have scholars here or faculty members. So this is actually an idea for a research. Definitely. All right, so I have another question I will take your question. I'll take your question. So I have a question directed to you, Dr. Samah. You mentioned that the caspase 3 has been increased very significantly when compared to the comparator groups for those who did not expose, and the 5 microgram, I believe. So how this actually element is, teratogenic, or the teratogenicity of this, element? Is it so serious, or it can be controlled by, some antidotes? And
regarding the low doses of the perchlorate exposure, the increased caspase 3, yes, it is already significant and increased regarding the uncontrolled group. But as I mentioned in the slides, it is not affect the cell viability, because the apoptotic mechanism is needed for the normal growth of the placenta. However, the highest dose is affected the caspase 3 and affected the cell viability. So it can lead to unavoidable pregnancy outcome that is not needed. It can lead to intrauterine growth retardation, and it can lead to preeclampsia, and can lead to fetal death. So we recommend to visit this permissible concentration again.
Thank you so much. We'll take a question here. Yeah, the other mic is better than mine.
Yeah, of course. Thank you very much. My question is about the inhibitors for PD-L1. You mentioned different inhibitors. Is there any difference in terms of, let's say, the adverse events?
Between each group, you mean?
Yeah.
Yes. Usually between each group of the immune checkpoint inhibitors, there are differences in terms of incidence of some adverse event. There is no unique adverse event related to one group. However, the difference is the incidence of the adverse event. For example, for pneumonitis, more common with PD-1 inhibitors. However, it's reported in a lower rate with CTLA-4 inhibitors.
Yeah, again, I'm totally agree with you, Doctor, that our population different from the others. And this is what I focused on yesterday on my lecture, that there are many polymorphisms which is common outside in European country, it's rare here, and vice versa. And maybe this is because, and as you mentioned, that our population respond differently to the immunotherapy. I'm totally agree with you. And for this reason, we need to have our own database for our population. I mean, to have our own genetic makeup for our own population, because really nowadays we are depending on the European database as a reference genome to compare our genetic variants to the reference genome, European reference genome. And we need to have our own reference genome. Thank you very much.
Thank you so much, Doctor. I agree with you 100%. You know, the genetic moiety of our population actually is different. And we need actually to have more research addressing this issue. And I believe, you know, certain medications, for example, let's say Plavix. Plavix, you know, most of the patients are actually fast metabolizers for Plavix, which is, you know, something that need to be actually studied further and to come up with the recommendation that can be generalized nationwide. With this, we reach to the end of the session. Thank you so much for everybody actually who stays with us until the end of this session. I know it's late afternoon, and I really appreciate the commitment that you made to this session. And I just want to actually extend the gratitude to our esteemed speakers who actually shared with us a great knowledge and helped us actually to know more updates about what's happening actually in their practices. Thank you so much on behalf of the audience and on behalf of the organizers and the whole conference team. We have recognition session.
دكتورة سماح فتحي. دكتور ناصر القحطاني. دكتور عبد الرحمن العنزي. دكتور سليمان الزبيري. Now we reach to the end of our beautiful CASAP journey. In every journey, we need to honor the work of everyone. So let's please invite Dr. Maha, Dr. Ahmed Al-Anizi, Dr. Muhammad Al-Mazna'i, and Dr. Abdul Man'am Al-Hamdan to the stage to honor the following participants. عقيل العباد، مسفر العتيبي، عبد الله العمر، مريم الملحم.
إذا تكرمتم المتطوعين الكرام ممكن تجون قدام كلكم، المتطوعين كلكم تفضلوا، أنتم من أقام الحفل، تعالوا خلوكم قريبين هنا.
محمد الزين، ضوى شوعي، زهراء عليوات، رضا الطريفي، محمد الزين، علي القاسم، حسين الجساس، زهرة خيري، رائد الكويتي، عمار البيات، وهيبة الدوسري، منار الغامدي، زينب الحمد، محمد الفيفي، آمنة النوبي، نورة أبو نيان، العنود البكر، زود العقيص، ريناد الخبراني، العهود الصالح، دانا اليوسف، دعاء أبو الرحي، علي المبارك، علي الجبر، فاطمة الربيع، هاجر الصقر، شعاع العلي، وجدان البحراني، شهد القحطاني، خالد الأحمري، شهد الكحلة، لمى الحربي، أرجوان القرني، كوثر الحداد، محسن الشويكي، جمال العسيري، سارة اليمني، كوثر زين الدين، خالد العصيمي، هبة المطهر، معن العلواني، فيصل العنزي، منار العنزان، سحر السبع، وفاء الغامدي، مروى الماجد، أمجاد العبيد، ديما الأسود، سارة القحطاني، عبير العنزي، مريم آل مسبح، زهراء آل درويش، أسيل العبد الهادي، نور السبيعي، حنين المبيض، وجدان اليزيدي، ياسمين المحمد، رباب العامر، سلوى العبد الكريم، عبد الله العبد الله، عبد الله الحمر، لينا الهاجري، البتول المؤمن، نور العجمي، لينا آل مدن، فاطمة القطان، أحمد المهنا، رنا السعدة، وأخيراً منيرة الكليب.
الله يعطيك العافية منيرة، من المميزين جدا، منيرة الكليب، الله يعطيها العافية.
كل نجاح وانتم بخير، كل نجاح وانتم أبطال، والله يسعدكم. شكرا جزيلا لكم، والشكر الأخص للي أصر أنه يكون معنا لغاية آخر لحظة. شكرا متحدثين الكرام، شكرا من اللي استنى معنا من اللجنة الاستشارية، شكرا لكل عضو منكم، شكرا لمتطوعينا المتميزين اللي كانوا شغالين ليل ونهار قبل المؤتمر وأثناء المؤتمر وإلى غاية آخر لحظة. شكرا جزيلا لكم. كما قلت يعني سابقا، الاستمرار هو أساس النجاح. يعطيكم الصحة والعافية رب جميعا. وراكم بإذن الله قريبا للاستعداد لكسابت 23.